little bit. Okay, see where we were. All right. So basically, where we left off, we started talking a little bit about trauma patients. We started talking about some of the natures of illness, or I'm sorry, yeah, the nature of illness and the mechanism of injury. Again, those are two pretty big, pretty significant terms that we're going to start using pretty much on a regular basis. I can't think of times where we wouldn't use those terms. A lot of times when you're presented with some type of scenario, that scenario is going to be kind of formed around your nature of illness or your mechanism of injury. So we talked about a little bit of that. Going back a little bit, we talked about just trying to basically get trying to assess. We have the conscious patients, we have the unconscious patients. Some of that we talked earlier about some of the initial life threats and things like that. So I don't want to necessarily go backwards in that, but that's kind of where we've been. And then moving forward from today, this was all just kind of a review of the general body systems. So as we're going through, this is still talking about some of our history, trying to obtain just that general impression, that load and go, or that stay and play, or how sick are they, sick, not sick. So again, I'm going to move kind of quick through some of these because again, a lot of this is just going to be review. So when we're going through some of the stuff we're looking for, we're checking on the skin. We move pretty much through all the ABCs, and this is all that primary assessment. So does the patient have anything significant that we're looking for here? And again, we've already managed these life threats. That's the important part about this particular part of the scenario. The life threats have been handled, a tourniquet's been placed, somebody's breathing for the patient, CPR is being performed, whatever it is, and this is going into our actual body system assessment. So like the head, neck, some of this stuff, we're looking for this for minor reasons. But if some of these start to add up to something else, that might give us a better differential. So for example, a headache and a loss of consciousness, those combined with, maybe some history that the patient was a little bit altered. Maybe the patient fell, lost balance. So all of those things can kind of lead you down a stroke path. So looking at that, asking some basic questions about ears and eyes. Photophobia is basically a sensitivity to light. As far as terminology is concerned, that's pretty important to understand. The way National Registry does a lot of the questioning, it's not that the question itself is difficult. What ends up happening though is you're reading the question and you have to understand a couple of the key terms that are in the scenario that are actually in the question to be able to answer it correctly. So if the question is, the patient has photophobia, they have vertigo, and they have something else, what can this be an indicator of? So being able to understand the terminology that's used in the question is going to help you answer it. So photophobia is that sensitivity to light. So again, they like to use that. When if a migraine patient, if you look at a light and it makes your head just throb, that's an example of photophobia. So that can be benign, where it's not that big of a deal, or that coupled with some other things can absolutely kind of lead us down a path of something different. So, and again, this patient assessment, this is all still just a general overview of the body. Once we hone in on one specific thing, or one or two, or maybe even three specific the differential diagnoses that we have, then we're going to go into this very, very focused, this hyper localized assessment of these patients, of that particular body system. So if we can identify that it's a breathing issue or a lung issue or pulmonary issue, then we know for sure that we're going to be able to hone in on that later. But right now we're just trying to narrow it down to what body system we're even dealing with. So we go through, and as part of some of the neurological exams, we do care whether or not they can smell, because again, cranial nerve 1 is that olfactory. Their ability to smell is directly tied to their neurological function. So there are times where that's a pretty valid thing for us to be able to assess. Epistaxis, what is that? Anybody? Nosebleed. That's exactly it. So that's again a common term that we'll kind of start using moving forward. So the endocrine system, this is something that's really difficult for us to assess, but we know that the thyroid gland, we know that a lot of that stuff kind of lives in the neck. So if you're picturing this assessment, we're kind of going from the head to the toes, and that's kind of the ideal way to do this. You start at the head. Do you have a headache? Is your vision affected? Is your nose affected? Can you speak? Are you speaking clearly? Do you know what words you're using? Speaking of that, when you're assessing people's language, there's two different types of struggling to of talking, of speech and speech problems. One of them is dysphagia. Dysphagia is a technical term for slurring. So when you're drinking, when you're drunk and you're slurring your words, dysphagia is the word that they use. It's dysphasia. So dysphagia. And then there's aphasia, and aphasia with an A is somebody that just can't speak for some reason. So you point to your watch, you point to your head, you point to something, and they cannot use the words. They cannot figure out what word to physically use. So those are just, as far as speech is concerned, that's one way that you can kind of talk about, trying to figure out the speech. So moving down, this is kind of the endocrine, and again, they localize that kind of to the neck because that's where a lot of that magic happens, and they go through some of these things. So polyuria, anybody want to take a stab at what that is?
Excessive peeing.
Yep, excessive peeing. Polydipsia.
Thirsty.
And the last one, polyphagia.
Hungry.
What are those three tied to? What disease process?
Diabetes.
Spot on. So if they're excessively thirsty, if they have that dry mouth, and they just can't seem to fix that, and they're peeing a lot, that's the body trying to excrete that extra glucose. So those three are absolutely tied 100%. When communicated together, when listed together, that is 100% a diabetic patient. So when registry asks the question, or when later on when I start asking the questions about this, these are the terms that I'm going to use for this. So those are pretty important to understand, especially for documentation purposes. All right. Chest and lungs. So we've moved down into the chest and lungs. Really what I care about is, are they breathing? Are they breathing appropriately? Do they have a productive cough? Basically this stuff right here. For a trauma patient, if we're going through and trying to figure out a mechanism of injury, our localized exams are going to be a little bit different. I'm going to be pressing. I'm going to be listening. I'm going to try to feel that crepitus in the lungs, or I'm sorry, in the rib cage. If they're spitting up or coughing up some kind of blood, that hemoptysis is a big thing for us to kind of think about. If they've taken some kind of blunt force trauma to the chest, like a steering wheel or something like that, they could absolutely have some kind of perforated lung, and that could create bleeding inside, and that bleeding can be manifested by coughing. So just again, these are, we as an EMT, if you having trouble, do you have trouble breathing? Is your heart beating? And with the lungs, do you have equal breath sounds? Those are really the big things that we're looking for. As a paramedic, we're looking a little bit deeper. So what is the quality of those breath sounds? What is the quality of the heart rate? Is it regular? Is it is it regular or irregular? Is it not only is it present, but is it strong, or is it a weak pulse? So things like that, we're starting to kind of add on to what we did previously. So previous cardiac events, naturally, if you expose a chest and there's a big zipper on the chest where somebody's been in there rooting around, we know that they have some pretty extensive cardiac history. So, those patients, we need to start thinking about going to a specific cardiac facility. And, whatever pain they're experiencing in their chest, we should probably take a little more seriously. Not that we don't take all of it seriously, but we take it a little bit more seriously than the 20-something-year-old that says, hey, my chest hurts because, I'm out of breath or whatever. So orthopnea is basically having a hard time breathing positionally. So there's we'll get into a little bit more of that kind of moving forward here. The hematologic system, we're not going to do much with this. We're not going to other than are there obvious signs of contusions or damage, or that decap BTLS? If that stuff all exists, then obviously that's a notation. That's nothing that we can necessarily fix or take care of or change. So gastrointestinal, this doesn't particularly matter to the EMT, and it doesn't particularly matter to the paramedics in a lot of ways. I don't necessarily care about food allergies. I don't necessarily care about their digestion history. What I do care about is whether or not they're producing urine, because again, if they're not, then that could be an indicator of some kind of dehydration. Do they have some kind of blood in their vomit? Are they vomiting? Do they have blood in their stool? The easiest thing with the stool, nobody really wants to talk about that. Nobody wants to ask about that. The other thing, menstrual cycles and stuff like that, nobody wants to talk about that. But generally speaking, again, we're professionals. That's something that's absolutely going to dictate some of our treatment, because it's going to dictate kind of what's going on with that particular patient. So, again, chest pain with heartburn, with nausea, vomiting, and with like diaphoresis where they're sweaty, all of that sounds just like a heart attack. So, a lot of people that experience a heart attack for the first time, they complain of indigestion. So this heartburn is a pretty big deal for us to ask about. Jaundice, we talked about that the other day. That's kind of that orange eyes, like in the whites of the eyes are kind of orange or brown or kind of discolored, and their skin's kind of got an orange hue to it. And again, that's kind of an indicator of a liver problem. And that's really about it for gastro. We do talk again. We talk about we ask about the menstrual cycle. The big thing is for when you're assessing a woman that has any kind of complaints of excessive bleeding, we try to measure that with is it more than normal, and then the other question is typically how many pads per hour you have to go through to try to control that bleeding. And if they can't necessarily give you that, then over the course of a 24-hour period, what did it physically take for you to control that? Because that tells us that would tell long term, that would tell about how much blood was lost and whether or not it was necessarily excessive or not. So, and then is it painful? And, there's a bunch of different questions that you can ask. And ideally, you're going to have a provider of the same sex go through that. And again, that's ideally, that's not always possible. So the big question is, if they're of age, of childbearing age, is there any chance that you can be pregnant? So this abdominal pain run for, a 16 or an 18 or a 20-year-old, that with acute abdominal pain, that could be a pretty significant medical emergency. So, being able to ask, when was your last period? Is there any chance you could be pregnant? If no, why not? Or if so, why so? And then whether or not they've had some type of prenatal care. Those are all pretty important questions to ask. And again, that's going to dictate kind of where we go. If this becomes a pregnancy related issue, then obviously we need to go to a pregnancy hospital that's capable of dealing with that. Any questions on that stuff? Nothing? So on assessing the male, the erectile dysfunction medication, we know as an EMT when we're talking about giving nitrates or some kind of nitro for chest pain, we know that this is a big deal. Erectile dysfunction, those medications by nature, they enlarge the blood supply. So if the blood supply is enlarged, that happens to be one of the main reasons that nitroglycerin works for the heart attacks. If one of the vessels in the coronary system is blocked, that nitro is going to expand that vascular system. So if it expands the vascular system too much, then naturally gravity is going to take over and they're going to be hypotensive. So that's the main reason we can't give nitro for somebody that's taking the erectile dysfunction meds. And then any kind of discharge it's not urine. I mean, obviously we're going to have a problem with that. Specifically, if there's pus or God knows whatever else. So things to think about. Again, these questions are not necessarily acute in nature. These aren't questions that are necessarily going to affect our early on treatments. The only difference, the only, I guess, caveat to that would be some type of disease process. And then, we all know a disease process left unchecked can go into more of a shock, more of a sepsis. So those are the things that we're kind of looking out for. But otherwise, I'm not too concerned with us going real deep into this. The only other thing is part of that, if we go back to the mechanism of injury, an abnormal erection after like some type of traumatic event, we'll talk a little bit about that moving it once we get into trauma. But when we're checking, that's definitely something that can be an indicator of a spinal issue. So neurologic function, we could spend a lot of time on this, and I don't want to because we're going to do it again later in medical stuff. But neurologic system in general, any loss of consciousness is something that we should obviously concern ourselves with. There's nothing more disappointing though when we have this patient that we swear is sick. They act sick, they look sick, they present sick, and when they get to the hospital, they're 100% normal and they're up talking. And I think we've all had these patients. They're just almost inconvenienced that you took them to the hospital, where 15 minutes ago you weren't sure if they were alive or not. So these syncopal episodes, people either have them and they know they have them, or there was something acute that happened that created this. That could be anything from hyperventilation. We know that hyperventilation blows off all that CO2 in the body. When all the CO2 in the body starts to dissipate and go away, the brain has some sort of there's a problem. It knows there's a problem, and all it knows how to do is reset. So to reset, that period where it resets is this syncopal episode. Most of the time they're benign. Nobody really worries too much about them, specifically the hospital providers. They don't particularly care. And as far as seizures are it's kind of scary to think about, but a lot of the doctors will honestly, they'll tell you that everybody gets one free seizure. Everybody in life gets a free seizure. If you have more than one, then they start doing some significant workups. And I know this to be true, specifically because my son had a febrile seizure, which is not uncommon whatsoever. But again, there was no workup done at the hospital. And that was pretty surprising to me to know that, I saw this god awful thing and this full tonic clonic shaking seizure. This whole thing happened, and then the hospital just kind of, it's not a big deal really. It's just one, maybe if he has another one, we'll cross that bridge. So thinking about seizures in general, the bystanders, the people that see a seizure, that's the worst thing in the world. It's a violent thing from a loved one. That's, this is not normal. And again, it's just kind of a horrific thing to look at and see. So with seizures, we got to take them seriously, but as a clinician on our side, seizures they're not that awful. Breathing is the thing that we need to worry about, and making sure that they don't fall and hurt themselves. So once the seizure stops, either because we made it stop with medications or it stops on its own, seizures in general are relatively benign. We're kind of worried about what caused the seizure. And again, that goes into a whole laundry list of things. And again, the brain doesn't really, it's kind of a dumb thing. It's kind of a dumb organ. It doesn't know really what to do except either turn off or have these seizures. So it could be anything from hypoxia to blood sugar. So it could truly be a whole bunch of different things. And of course, there's a bunch of different types of seizures. There's the seizures where, you can look in somebody's eyes and their eyes they're just localized to one side. Maybe they're in there bouncing a little bit. That's pretty common with kids. When you look at a kid that's not responding to you, specifically a baby or an infant, if you're looking at them and you're trying to stimulate them and they're not responding to you at all, if you look in their eyes, there's times where they're lateralizing kind of to one side and that eye is just kind of pinging on the side. And it can even be subtle. It doesn't have to be fast, but any kind of rhythmic movement of like the eyes or one specific body part, we know that that's a seizure, and it's not necessarily the seizure that we've seen in the movies or even in practice. There's probably been quite a few seizures that you guys have missed because these do happen relatively often with some of our sick patients. And again, it doesn't necessarily manifest itself as this full on this body shaking that we've come to identify. Neurologic. So other than those, we move into stroke assessments, facial asymmetry. So, a facial droop of some kind. And still to this day, the national standard is still to use the Cincinnati Stroke Scale. We know that the Cincinnati Stroke Scale, there's a whole, let me back up a minute. There's a Cincinnati Stroke Scale. There's a Los Angeles pre-hospital stroke scale. There's an NIH. There's like a full, the hospital version of the stroke scale. There's a whole bunch of them, but each one of those is typically localized to the region. It just so happens that Cincinnati came up with a pretty good one, being able to assess motor function, equal motor function and speech and things like that. So we're going to use those scales, and we'll get into doing those kind of later, but we're still going to use those even on the paramedicine level. Psychiatric stuff, this is another one of those runs where Scene safety is really going to be paramount. Once you've identified that the scene is safe and everything's good, really it's just trying to get them to an appropriate facility. And those facilities are starting to become overwhelmed. So, and it's not necessarily right now because of pandemic type issues. The psychiatric in general, Children's Hospital, they've seen like a pretty significant increase or influx of psychiatric patients. There's not really a rhyme or reason. They're seeing a lot more. So places like Fort Hamilton and some of the other hospitals are starting to they've quickly become flooded, and they're starting to kind of scale back what they offer. So knowing your local psychiatric hospitals is going to be pretty important for your area. So basically, we know this is kind of the overview. We know that we're looking for the chief complaint. The goal of the assessment is to try to figure out what body system we need to hone in on. We're going to do that by basically taking all the information we've had. We're going to try to apply that within a protocol that we have of some kind, and then we're going to try to treat it. As we treat it, the big thing for us to do is go back, make sure that our treatments are working, make sure that we're ultimately going to get to the intended outcome that we're planning. A lot of times this all happens kind of automatically. I know that as soon as I give nitroglycerin, I'm going to turn around and ask them in the next minute or two if that's relieved the pain. If I give fentanyl or some type of pain medication, same thing. I'm going to ask them, did it help? And if it didn't help, I'm going to do it again. I'm going to give them another one. And if it did help, obviously that's when we can start moving on. So as far as us trying to figure out our differential diagnosis, this is kind of where this is going. We have to take all this information. We come down basically to, I know what disease processes are. I know what the body does. I know how the body reacts to different disease processes. And I know what the patient physically said the problem was. So if I take all that stuff and I combine it together, that's going to give me that differential diagnosis, which basically is a working hypothesis. This is what I really think that this is. So again, if you're dispatched to a 46-year-old male with chest pain, you get there, that 46-year-old male says, "Hey, I was out in the yard and, acutely, quickly, while I was cutting the grass, my chest started hurting really, really bad. Worst pain I've ever had in my entire life. And, here we are." And you show up and this patient's cool, pale, and diaphoretic. You can start working down that path simply by knowing what the dispatch was. Sometimes can help and sometimes can hurt. Because again, these people that are calling 911, they don't necessarily give you 100% of the information, and dispatch doesn't necessarily know, God love them, what exactly to ask. So you got this patient, they're sitting on the back patio and they got this substernal, this crushing chest pain, and you start asking questions. Hey, have you ever had a heart attack before? Do you take medications? Whatever, have you been outside too long? Is it hot outside? So you start thinking about all this stuff. And with those questions, I've narrowed it down in my head so basically we have this acute chest pain. So either it's a cardiac event, so a heart attack, some type of pulmonary embolism or something else that would cause some kind of chest pain on breathing, or is it like a heat exhaustion? So now I've got 3 working differential diagnoses. So those are my 3 hypotheses. So from there, I'm basically going to go through and say, okay, well, this is the chart. I've got all the history taking. I've done my primary survey. They're talking to me. They're breathing. So I'm okay with all of that. So how do we start to determine this? So, how do I start deciding which one of these 3 it is? That's when you have to do this physical or this focused exam on that particular body system. So I'm going to get some vitals. If the vitals look terrible, then I know the heart's involved. I'm going to use a 12 lead. So when I get the cardiac monitor, that is going to roll in right by itself. That cardiac monitor is going to roll in or roll out one of my 3 differential diagnoses. So if I put them on the monitor and the monitor is 100% normal, then I can take cardiac event off the table. So now I'm left with this pulmonary embolism or this heat exhaustion. My basic vitals, I could probably tell, has he been outside too long? Is he hyperthermic? So I can start figuring out whether or not I think that's truly it. So again, this is just a working hypothesis, and you have to keep questioning during these assessments, specifically the secondary assessment. I have to try to figure out which one it is. So basically during this secondary assessment, they say it's quantifiable. So it's something that I can physically see and appreciate. It's not just a feeling or an opinion. This is some objective information that we can take from that patient's overall health. So have you had that heart attack before? Yes or no? Have you been outside in the 100-degree weather for an hour or 2? cutting grass? Those are all very important questions for us to try to quantifiably decide which one of these routes we're going to take. So again, the two big ones, you take the vitals because you can't change those, you can't alter those. Those are very black and white, and you do this systemic physical exam. Are there any glaring things that you have physically seen with your own eyes that can lead you down one path or the other? So again, the 12 lead, that is a very, very specific black and white thing that you can look at and say, yes, definitively, you are having a heart attack, or definitively, no, I don't think you are having a heart attack. So those are very, very specific, quantifiable, objective things. So going through it, we have to kind of decide. So how and when do you do it? Do we stay in the backyard? Are we going to load them in the ambulance? Turn the AC on, see if they start feeling better. We're things like that, and some of it does come down to some experience, some things that you've seen before. There's, for some reason, last year was a terrible year for us with grass cutting. There was nothing more hazardous to somebody's health than going outside and cutting grass. We had all kinds of people falling over. So that was just a weird year for that. But that, when you go to one and you know that you've gone on two other ones and you know that those two other ones didn't go well, that absolutely lends to your clinical judgment. So that's going to hold true for everything. Once you see a cardiac patient that's truly dying in front of you, and without intervention, they're going to die, you'll never forget that. And when you see that again, you'll know it. And that's something I can't teach you. That general gestalt, that general feeling, that impression that you have, that's not something I can teach. So that's pretty important for you guys to kind of pay attention to now. When you look at a paramedic who's not normally a spaz and they're freaking out on a run, that's a pretty good indicator that you need to start making mental notes of what's going on here. And that's the last thing you're going to be thinking about, because you're going to be trying to do airway and trying to do cardiac stuff and chest compressions and whatever else you're tasked with doing. But again, right now is a good time for you to take that information in and try to figure out what you would do. And as you start thinking and watching other people, you'll know who you trust. You'll know a good paramedic from, maybe a not so good one. And then you'll be able to kind of take that and kind of formulate your own judgment moving forward. This talks about some of the factors, and that's basically if they're tolerant, then you can do this stuff. If they can communicate with you, if they speak a different language, obviously this is all going to be exponentially more difficult. I'm going to skip through some of this. All right. So the physical exam, they say a 60 to 90 second should be sufficient. Now, again, a lot of this is very, very specific to what the patient says. If the patient's telling you that, he's having, he got stung by a bee in the arm, I don't particularly care about the neurological exam. I don't particularly care about that. I know what the problem is. It's very easily quantifiable. You got stung by a bee, you have swelling, it is what it is. So that 60 to 90 second really it's just a general, this general overview. Are you in some type of anaphylactic shock? Are you having some kind of significant problem? And that's really, again, that's very dependent on what's specifically wrong with the patient. As far as trauma is concerned, that's a little bit different. Trauma patient specifically post, like in any kind of acute trauma in general, the brain does a really, really neat thing. And we call it's retrograde amnesia is the fancy term for it. But basically we've all had the patients where you walk up and say, what happened? And they say, I have no idea. I don't remember any of this. You may ask them where they're coming from, and they may not even be able to understand or be able to comprehend or articulate to you where they're even coming from. That is that retrograde amnesia. It's that amnesia or the forgetting after the fact. So the brain does that, and it's kind of a compensatory mechanism that's kind of protective. It prevents them from revisiting that specific trauma. So when you ask a patient, hey, what hurts? They may not know. They may not even know where they're at. So this 60 to 90 second, this scan is supposed to be, it should be used on all of these patients because again, they can't localize pain specifically right away. So things to kind of think about when you go through, you're looking for, again, that DCAP, BTLS, those deformities and contusions, abrasions, and you're looking for anything significant that you're going to have to otherwise treat at some point. So for us to do that, this is kind of our head to toe. You're gonna physically, this is where hands on, and again, the no modesty in EMS, you have to remove clothing that's going to hamper your ability to visualize the skin. um, with the pulses, we know there's several different places, and once we get into cardiology, you guys will know that there's some pulses that are better to check than others. We'll know that if you can feel a carotid pulse, that we'll know that they at least have a blood pressure somewhere in the 80s, and that's all good information to know. A lot of times, some departments with the blue or the dark blue or the purple or the black gloves, sometimes those are difficult, because if you're scanning around, a lot of times you just kind of do a sweep of like the back and you look to see if you have blood on your glove. If you can't see that because of the color of your gloves, that can potentially be a problem. But a lot of this is just us, again, trying to do this down dirty quick scan of the body. Percussion is, so as we're going through, this is actually, it's an important theory to understand that is never ever used. You won't ever use it, which means there's really no reason to learn it. But the problem is, there will be questions down the line about it, and there are some diagnostic cases, and there's some diagnostic value in it. But basically, it is literally striking you with a finger or two fingers specific parts of the body. So if I put a stethoscope right in the center of somebody's chest and I tap on one side of their chest, you get that thud, that whatever that noise is that you have. If you go to the other side and that noise is different, then that sound didn't resonate through the body appropriately on one side or the other. So if they're different, then we know that there's something going on one side or the other. So that can be excessive fluid that's built up. That could be blood on one particular side. So when you tap and you hear this really, really dull, real faint thud, and on the other side, it's kind of a hollow noise that it's supposed to be, then obviously that's an indicator that there's maybe some kind of collection or something that's hampering your ability to hear that. So a normal lung, there, it should be kind of a medium, kind of a loud, and it's hard to quantify this, but it's kind of a low pitched, normal sound. As you move through, there's, if you're tapping near a hollow organ, you should hear more of an echo, more of a, the term is tympanic, but it's essentially kind of it's just kind of a hollow noise. So what I need you guys to know is that percussion in general is the tapping of the surface to try to determine whether or not there's something accumulating underneath, whether it's blood, fluid, edema, something like that. And this is truly something that takes a lot of practice to actually get good at. You may see doctors that they'll put their hand over a spot and they'll tap their hand. And again, a lot of that is just whatever they have trained themselves to physically do. In the book, if you guys are following along, I think it's 11-2. There's a page that actually goes over the actual skill for that. And again, we'll mess with that a little bit, but again, I don't expect you guys to be good at this. And again, I can tell you that I've never done this myself. If they're having a hard time breathing, I'm going to use my ears. I'm going to auscultate. I'll listen. If I would note that there's something more dull on one side than the other, then I would expect to not hear as well on that side. And I put more faith and effort into that because I've practiced that far more than I've practiced something like this. So speaking of that, so listening, this I cannot stress enough. Every single patient that you have, and it's worth repeating, every single patient that you have starting today, I think you guys should be able to take a stethoscope out and listen to lung sounds. This is going to be a really, really difficult thing for you guys moving forward. You have to know right now definitively what a wheeze sounds like when somebody's wheezing. You have to be able to differentiate that from stridor, which is an upper airway, more of a squeak or a squeal. Those two things specifically, they separate 4 or 5 categories of very, very, very important differential diagnoses. So if you can't determine whether or not you're hearing a wheeze or something else, then you're having a hard time even deciding whether or not it's an upper airway problem or a lower airway problem. So being able to hear that is super important. So for you to understand what the problem is, you have to know what normal is. And I know we've listened to lung sounds, but we listen to make sure we hear airflow and make sure we don't hear the sounds of somebody that's underwater. Those are very, very obvious ones. But what I need you guys to start doing now is when you're listening, start making mental notes of what you're actually listening to, what you're actually hearing. When they take that breath and you hear that inhale going into the lungs, is it smooth? Is it consistent? Do you hear bubbling? Do you hear any kind of tightness? And you'll know what tightness is specifically by just trial and error of doing this. When they wheeze, are they wheezing on the way in, or are they wheezing on the way out? Those are very, very important for us to be able to treat appropriately. So the only way you can do that is to start practicing now before your treatments have to truly be dictated by what you're listening to. So you got to know what normal is, and it does take a lot of practice. So lung sounds, we're listening, we're breathing, we're going through. You've probably got a partner at this point taking vital signs. This is a screenshot, is what this needs to be for you guys. This is something that's going to be really important, and this is going to follow you. So being able to know what normal is, how do you know what a normal blood pressure is? What's always weird to me is the neonate and the infants. Their blood pressures are very, very low. A lot of times their sugar is very, very low, and you move into, as you get older, everything starts to increase a little bit. So knowing, except for ventilations, the actual ventilations, which as you can see there, it says respirations, which drives me nuts, but the ventilations, 30 to 60 times a minute. So they're breathing every second for these the new babies, the neonates. So again, this is a screenshot. This is in the book. This is pretty important for you guys to understand. We'll go a few more and we'll take a little break. So the pulse, again, we're thinking like medics now. We are not thinking like EMTs. Yes, there's a pulse as an EMT. Yes, there's a pulse. We're good. We're good. Let's go to the hospital. That is just a scratch of what we're supposed to be doing here. So what is the patient's baseline? Is the patient a runner, or is the patient an ex-boxer? Those are two very, very different people. Somebody that sits on the couch and leads a relatively sedentary life, they, by just sitting here like you and I, their pulse might be 80, 90, maybe even 100. If you are a runner, you could take your pulse, and your pulse is probably 50, 60, something like that on a good day. That is a big deal for us, because in a protocol, if I slid a protocol across to you, somebody's complaining of chest pain, and their pulse is 58. According to the protocol, you have to treat that. You have to fix that, because that's abnormal. But for this patient, it is normal. So being able you have to go through the history process. You have to figure out, are you otherwise healthy? What is your pulse normally? What is your blood pressure normally? And things like that. And I think we know how to check that. You feel it. 30 seconds, you multiply by 2, that gets you the minute. I'm gonna skip through. The only thing I want to mention on this, just because it's a good picture, the middle picture, this is the femoral pulse. Your femoral artery runs right down through the inside from the groin down. That is one of the hardest spots to feel a pulse, but it's also one of the most important. When we're doing CPR, if somebody's on the chest doing CPR, somebody can be right here making sure that CPR is truly being effective. What that also does is when that person stops doing CPR, if that patient has regained a pulse, as long as this person has been able to feel a pulse while CPR is being performed, then as soon as CPR is not being performed, they can adequately decide whether or not the patient has a pulse, because they know that it was there. So again, and this is one of the most abnormal ones for us to be able to learn, because, we're not necessarily checking this on our friends on a regular basis. So just a thought, but that is something that we're trying to incorporate in the pre-hospital world into our cardiac arrest runs. So ventilations, the ventilatory rate, we're going to check that. If somebody's clearly having an increased work of breathing, they're tripoding, they're leaning over, you can see that all of their muscles in their chest are retracting every time they try to take a breath. We know they're struggling. That's really all we need to know. Yes, you're struggling. Why are you struggling? That becomes our question, and that's kind of where we go down our treatment path. So are you struggling because you have asthma? Are you struggling because you're 400 pounds and you just walked outside to get your mail? What is it that's creating this particular issue? So going through that, listening to it, is it regular? We're going to talk about some of the different types of ventilatory rates, or the qualities. And I think actually we're going to talk about that, I believe, here in the next slide. Yes. So this is something you guys have to know. So here we are. I'm going to go back a slide a second. So we're listening to somebody's chest. we know that the lungs are bigger than where we normally put the stethoscope. We usually put it right on the upper pec, like pectoral muscle, and we listen. Technically, when you're listening, you should go equal sides. So you want the same spot on both sides, bilaterally, so that you can compare the two. So a lot of times you'll go high, you'll go mid, and you'll go low, and then you'll go laterally. And then if you can hear the same, usually the sound from the top to bottom is going to be different on both sides, but as long as it's the same bilaterally, you're in good shape. And then again, the last couple spots is in the dead center of the back. So we know that the lungs anatomically, there's more muscle tissue and there's more fat and adipose tissue on the front. So a lot of times you'll be able to hear better on the back, because the lungs are technically closer to the posterior side. So being able to put a stethoscope on the back, you might be able to actually hear a little bit better. So we know that we've got the the ventilations have been counted. This is really, really, really important for us. This is absolutely a take home. Write this down, take a screenshot, whatever you have to do. So apnea, we know flat out is they're not breathing. Bradypnea is they're not breathing fast enough, so they're breathing relatively slow. And then difficulty breathing is dyspnea. So understanding that and being able to articulate that and write that into a report is very, very important for us. So these are 3 different trouble breathings. So for us to be able to document that, again, before it was just the patient was found not breathing, or they had shortness of breath, or they had trouble breathing. These are the technical terms that you should be knowing, that you should be able to write down. And then moving into the irregular ventilatory rates. So this ataxic, or the BIATs, these are basically they're basically just completely irregular. There's really not a whole lot that we can talk about with that, other than they're just abnormal. Whoops, let me go back. Sorry. The Shane Stokes. Shane Stokes is going to be a really, really important one. Registry likes to use that particular set for some reason. This is the trauma patient that has suffered some type of brainstem injury. So Shane Stokes is, they breathe really, really fast, and then really, really slow, and then really, really fast, and then really, really slow, and then really, really fast, and it just keeps on going in that cycle. So that is something. Again, they'll usually use the term the Shane Stokes, but again, it's fast, slow, fast, slow, fast, slow. Kussmaul's is pretty much a dirty phone call, is what Kussmaul's is. It's a very, very deep. It's a very, very deep, very quick ventilatory rate. That is 100%. That diabetics is when they will ask that question. So Kussmaul's, any patient that has Kussmaul respirations or Kussmaul ventilations is going to be a diabetic patient. And again, that is just the easiest way to remember Kussmaul's, is it's a dirty phone call. Somebody's breathing deep and fast. That probably won't be the question, by the way. Tachypnea, opposite of bradypnea, they're breathing quick. So, if they're tachypnic, they are breathing quickly. This is probably the most common term that you're going to use pre-hospital in your report is tachypnea. They were tachypnic. That just basically means you're a smart paramedic and you're just saying that they were breathing quickly. So that's pretty important for us to understand. Any questions on that before we move forward? Okay. Blood pressure, we know blood pressure. It's the cardiac output and the peripheral vascular resistance. So is the heart beating? How hard is the heart beating? And how resistant is the vascular system to allow that pressure to stay as strong as it needs to stay? So systolic pressure, we know that is systolic, it starts with an S, so to squeeze. So systolic is the squeezing of the heart, and diastolic is the relaxing or the afterload of the heart. The take-home points here, systolic is usually what we treat on. If the diastolic number is a little bit low or a little bit high, I'm not typically as concerned with that as I am about the systolic. So if the systolic is, if their blood pressure is 80/40 or 60/40, that's concerning. If it's 200/100, that's also concerning. So I'm more concerned with treating based on the systolic pressure. The test question that lives in here is during which phase of the blood pressure does the coronary arteries fill? And we know that the coronary arteries fill during diastole. So everything else fills during systole. It's squeezing all the blood out to the body, with the exception of the heart muscle. The heart muscle is perfused during diastole, and that's the one difference in what's perfused and when. Please, when you're taking a manual blood pressure with a stethoscope and a normal blood pressure cuff, do not document an odd number, because there's not odd hash marks on the dial. So make sure that's an even number. Otherwise, a lot of what you say to the nurse or doc will be completely just eliminated, because they won't trust you. The diastolic pressure, we know that we can either auscultate, or we can take we can do it by palp or by palpation, and we'll I'm sure we're probably pretty good at that, but we'll revisit this a little bit later. But that's really all for that. Any question on blood pressure? I sent out the there was an article and an email that I sent out that talks a lot about the alpha, the beta 1, and the beta 2 medications and receptor sites. If you didn't read that, please go find that, and please understand that. That is really, really, really important. So alpha, any kind of alpha agonists, a lot of times they use that for blood pressures. A lot of times what that does is it tells the body to relax some of that peripheral vascular resistance. If those vessels are super tight, it's like a garden hose. If you put your thumb over the end of a garden hose and you minimize the size of that, the pressure is going to be higher, and it's going to be the exact same in the body system. If you let go of that, or you open up that vessel, it allows that peripheral vascular resistance to decline, which gives them a lower blood pressure. So that alpha 1, the alpha 1 medication, we know that the alpha relates 100% to the vascular system in the body. Those little alpha receptor sites live within the arteries. So we know that if I can block those, then I can essentially allow that vasodilation to happen, which would decrease the blood pressure. And since I mentioned it, beta 1 and beta 2, those are going to be important once we get into respiratory, which is coming up. Beta 1, you have one heart. So beta 1 affects the heart itself. Beta 2 is the lungs, because you have 2 lungs. So if you remember that, you've got all that you need. So I'll repeat it. Alpha 1 is peripheral. It lives in the arteries, has to do with vasodilation and resistance. That's the alpha receptors. Beta 1 is 100% the heart. Again, beta 1, you have one heart. That those medications directly impact the heart. So they make it squeeze harder or faster or whatever it is that they're designed to do. But it's all going to affect the one heart, beta 1. And beta 2, you have 2 lungs. Beta 2 is 100% for lungs. So albuterol is a beta 2 agonist. It gets into the lungs, and it allows that to be more receptive to oxygen. A couple more quick slides here. Temperature, what we use for temperature isn't really effective anyway. We have the tympanic ones. We have the ones where you can scan. Those don't work whatsoever. In fact, we make the joke every shift before work, like most of you guys, we have to scan in. We have to have somebody scan make sure our temperature's good, and whatever else, ask some qualifying questions. But they use that infrared scanner. I can reliably say 100% of the time I am 97.3 degrees. 100%. It doesn't matter what I'm doing. So that's kind of weird. But that is what it is. They're not reliable. You can add 1 or 2 degrees and get a little bit closer. But in general, they're just not super reliable at all. There's some that can go into the ears. Everybody has a little bit different things. But for us, we're not super worried about that. If they're super febrile and they had a seizure, that could be your indicator. If they're super febrile and there's really no reason for them to be high or with a fever, then that's some type of illness. That's the body's white cell system going nuts trying to fight this. So that's really all we're going to use that for. Let's take a little break. Nope. I got 3 left here that are pulse ox. We know what this is. We know how to use it. I'm not going to go into that. Here's some other cool stuff that we're going to use. We don't use most of the $4 words that are on there. Capnography. You guys will be so tired of hearing about capnography by the end of this class. The diagnostic value for that is off the charts for what you can physically do with that. So we're going to use the hell out of that. That'll be pretty important for us. Blood pressure cuff and all the other stuff. You guys are very, very familiar with all of that. We do know they do make electronic stethoscopes now that are they're really, really proud of them. They're $300 and $400, but they're more for cardiologists. They just amplify the sound, and that's really about it for that. Anybody have any questions on that? Nobody? Nothing? Awesome. Let's take a little break, and we shall be back in just a few. All right, so we're all good now. Cool. We already talked about the head to toe. We know the head to toe like this. So the first one, the whole first section that we did was kind of a non-specific. It was we're identifying the problem because the patient was able to articulate the problem, and we go through and we figure out that particular body system, and then we go into vitals. This is the full body for the unconscious patient. These are the critical patients. This is the significant car wreck patient. They go through and they get this full focus exam, and really the focus exam. Step one, like anything else, is life threats, identify them, treat them, move on. And then we're starting to get into some of the other stuff that goes along with the significant mechanism of injury patients. So we go back kind of to the head. Now, these are the more severe, the unconscious patients again. Are they alert and oriented to person, place, time, and event? Do they know what happened to them? Again, most of the car wreck patients or some of the significant trauma patients, they might not know anything about the event, and that's not abnormal, but that's also not super awesome. There was some significant impact. There was something that prevented their body from physically remembering that. So we use like for these 4 areas, we try to use like the AVPU to kind of determine are they alert to verbal pain? Are they just alert in general? And usually I'll document that by A&O times 4, and that's alert and oriented to all 4 of these. So again, it's person, place, time, and event. And then you can use GCS on top of that if you're again, you're dealing with your trauma patients. And again, they will not tell you specifically that this is for a trauma patient. They will just say this is a way of quantifying somebody's mental status. And again, right, wrong, or indifferent, it is kind of what it is on a scale of 3 to 15. And this is, again, there's that resource in the course folder for you to kind of look through this. The hardest thing is to try to go through and try to figure out with that, where to put somebody. Because these mental, if they're an 11, why are they an 11? If they're a 14, what's the one thing they're missing? Is it an eye problem? Is it a motor? What type of issue are we dealing with here? And just in general, when you're talking to a patient, they should be able to communicate with you. And when I document something like that, I usually put meaningful conversation. I'll use that phrase. Can they conduct meaningful conversation? If I ask them a question, can they give me a thoughtful answer? Is it just yes and no? Are they inappropriate responses? Those are all things that I'll try to document, whether or not it was appropriate conversation. So meaningful conversation is usually what I try to list in there. And some of that, you can determine real quickly if somebody has history of like anxiety, or if this is some kind of overreaction to something. Not that we can take anything away from it, but clinically, it takes us down a different pathway if we know that they're having some type of anxiety attack, and it's not necessarily that that they're actually dying. So skin again with these critically with all patients. If again, I'm looking for a pink, warm, and dry skin. Pink, warm, and dry. If it's anything other than that, there should be some kind of reason. Again, pink, hot, and diaphoretic could be outside. They could be outside cutting grass. So that's really all there is for that. So we're looking for color, temperature, basically the skin condition and color is what I need you guys to be able to do. Is it this pallor color? Like, is it kind of a gray or an ashen color? Are they diaphoretic? Are they blue? Are they blue? Is it blue under the fingernails or under the nail beds or in the lips? Those are all different places that you can kind of determine the color. So here's kind of that pallor, and again, really this is the color of the skin is kind of leaving. It kind of leaves that particular area because the actual perfusion at the capillary bed is poor. So you lose that pink color that your skin normally should be. Vasoconstriction, Again, us going through, we can go through these different things all day. But if the skin just looks unwell, it's unwell. If it's cyanotic or blue, then we know that it's an oxygenation problem. We can fix that. If the red blood cell perfusion at the capillary bed is low, we can fix that with fluid. There's a bunch of stuff that we can do to kind of fix some of these. This modeling, this is usually some type of shock patient. And again, that's kind of like the blotchy, the skin's just not perfused equally. Again, if you can't remember the terms, just know that these aren't normal and that we need to be able to try to identify these and intervene. This ecchymosis is that localized bruising that is pretty consistent with some type of problem, some kind of traumatic insult or something like that. Skin turgor, we talked about that in EMT school. But basically, you can pinch the skin on the back of the hand, and hopefully within a short amount of time, it restores and goes back to normal. By default, if you're over the age of like 60, you're going to have poor skin turgor. It's just going to happen. That doesn't necessarily mean that they're dehydrated. That may just mean that there is either excessive skin compliance, where the skin is a little bit softer and there's a little bit more of it. So elderly people in general are going to have poor skin turgor, but they're also going to have poor circulation. So just in general, they're going to check a lot of these boxes, and it may not be abnormal for them. Hair, there's that. I don't know much about that. So there's none of this is going to change anything that we have whatsoever. So I'll move on. Those fingers suck. That would be absolutely terrible. There can be a whole host of reasons why that's a thing. A lot of it has to do with either non-compliance in diabetes, or that could be a circulation problem. That could be a genetic abnormality. The fact that there's no pink under the nail beds at all. So that's basically that. That's definitely something that we can kind of check. Here is some of the weird abnormal findings for nails. I'm not too worried about anything except for the clubbing of the fingers. This is something that we are going to use as a diagnostic finding for this COPD patient. COPD patients will have clubbing of the fingers, which is it's kind of a squaring off of the fingers. There's a whole host of weird cellular reasons that this happens. I'm not really super particular about that. Just know what clubbing is. So write that down. And again, that'll show up later as a part of they'll be explaining a patient with clubbed fingers, and they're looking for what disease process this patient has. But this will just be one of the several findings that you go through and you see. So again, as we go through, I'm trying to allow you guys to have the things to pick out. When you see this is kind of the thought process that you could need to go down. But some of this other stuff, I don't particularly care. Terry nails, like the instances that you're going to be able to see and diagnose somebody with some kind of liver cirrhosis is going to be so low that National Registry is not going to typically concern themselves with it. And on the flip side of it, in the back of the ambulance, you're going to see this stuff, and it's not going to really matter. So it's cool. It's awesome. It's cool to think about. If you're the type that really needs more, you can go in and you can memorize some of this stuff. And I guess on that note, I'll also mention we breezed through, and I'm kind of reflecting back on some of this, but we breezed through the first several chapters really quickly. And it wasn't really quick, but we skipped over a lot of information. So, what the terms of, cellular breakdown is and all that other stuff that I said we won't necessarily need. And we won't. But I think it's also a disservice to you guys if you're in the boat or in the camp of really wanting to know that. So what I wanted to mention to you guys, and I forgot to do it earlier, but since it came up, if that's something you want, if you care about, sodium and potassium lab values, and if you care about, what actually happens on the cellular level deeper than what we discussed, let me know. Some of the stuff I'm not super awesome with once you get way down into the weeds. So for that, I would probably set you up with Brenda, who by nature, she is a phenomenal hospital RN. Like she's got all that information figured out. And I'm sure you'd have a better experience with her on something like that than the day that she showed up in Target's parking lot. with you guys. But honestly, if that's something that appeals to you, or that's something that you think would truly fix or round out some kind of knowledge, let me know, and I will do what I can. And if your questions and some of what you need is above what I have, I will absolutely put you in touch with her, or probably her, because she truly is. She has the ability to explain that stuff at a very, very high level. So keep that in the back of your mind if all of this is leaving you wanting more for some of that. But what I've given you is what you're going to need in the field, and what I'm giving you is what you're going to need for testing. So both of those things combined, that joint effort is what I wanted when I was going through class, and what most of my past students have wanted. And that's, what do I need to know for the test? And then how do I make this work practically in my life? So that's kind of the presentation platform that I'll have pretty much moving through class. So again, if you want more, let me know, and I'll give you more. But as a class, I'm trying to not go way off topic or way out into the field. All right, back to your regularly scheduled programming. So the head, again, trauma. These are trauma patients. This is a pretty significant impact that you're seeing here. She clearly has some kind of displacement of the nose. She's got that swelling around the eyes. That could be an outside trauma. That could be blood collection inside. That could be some type of sinus cavity rupture or something else that would affect that orbital cavity there. The fact that she's either unconscious or, whatever it is, maybe her eyes are kind of swollen shut, it is what it is. But that's what you're looking for. You're looking for these asymmetric injury patterns. And what I just did was I just described her injuries. And really, it was just by looking at a picture. That is what your report needs to do. Your report just needs to describe what you saw and in terms that make sense. So again, swelling under both eyes, blood collection, fluid, whatever, bleeding, laceration, whatever it is, you basically explain it the best you can, and you document it and move on. I don't necessarily looking at this as far as life threats. There are no life threats that I can see from the blood loss standpoint. Her airway, in my opinion, would be patent at this point. I have no reason to think that she doesn't have an airway that can be managed. If she's breathing on her own, then it's a self-managed airway, and breath sounds are okay. If not, these are the patients, specifically like the C-collar patient that's flat on a backboard. These are the patients where if there is significant breathing issues or bleeding issues, all of that, when you're laying down, any kind of bleeding in the lungs, if you think about your lungs as being kind of a 2-liter bottle, if you lay that 2-liter bottle on the side and there's a little bit of fluid in there, it's going to affect way more surface area than if you stood that 2-liter bottle up and it was just affecting the bottom. That's a pretty important thing to kind of understand. And I know we're not there yet, so I'll kind of hold off. But when you're dealing with the head and the face, a lot of that is connected to your bronchial tree, to your trachea. Are they breathing? Do you have to manage that airway? And that's something that you're looking for here. That's what we just talked about. If you don't know DCAP BTLS, do so. This is going to be vital for us. Deformities, contusions, abrasions, punctures, on and on and on. Please, please, please commit that to memory if you can. Looking at the eyes, again, there's not a whole lot you can do with eyes. Eyeballs are the bane of my existence. Eyeball injuries, I cannot handle that. And we'll talk someday about why, but eyeballs are that's my kryptonite. But there are several different chambers. They are supplied by several different vascular systems. They have blood flow to and from different areas. They also have multiple cranial nerves attached to them. So the eyes are super, super complex. They're also hollow. So or somewhat hollow. There's a lot of fluid, but they're easy to collapse on themselves. And that's no bueno. That's no good. So us looking at the eyes, the biggest thing that you would want to do with eyes, if you're going to do any assessment, pupil reactivity. So are the pupils equal, round, and reactive to light? So you shine light in, they constrict. That's the idea. If you've taken too much of the heroin, your eyes will be constricted in general. If you've taken too much of the cocaine on the flip side, your sympathetic response is kicked in. So again, back a few days, if I take cocaine and my central nervous system activates the fight or flight side of things, the adrenal receptors and everything is pumping out the fight or flight stuff in my body. The caveman way of thinking about that is I'm ready to fight. I need as good a vision as I can get. So my eyes dilate to open that hole up real big so that I can see everything and I can feel everything. So part of taking cocaine, it stimulates that fight or flight sympathetic system, and when it does that, again, your pupils are going to be huge because your body's ready to fight. It needs to let all the light in it can so that it can see as good as it can. So these are all indicators of drug abuse and drug overdose. That's kind of what we use it for. So big blown pupils. If they're equal, then I'm thinking maybe drug related. If they're unequal, so one's big and one's not big, that's a problem. Those asymmetric pupils, that is a problem. Now that can be some type of typical abnormality that's normal. Like they might not have two eyes. It might be something else like glass eye or something like that. Or it can be some type of brain herniation or some kind of TBI or traumatic brain injury. Because again, there's pressure on those cranial nerves. So if one of the cranial nerves has some swelling in the brain that has impeded that cranial nerve, then that one eye won't be able to adjust appropriately. So that's kind of the importance of understanding the cranial nerves are tied to different facial features. Bleeding in the eyes, that is what it is. You'll look at the eyes and go, yeah, that's no good. You'll cover it up and you'll go to the hospital. So assessing pupils, this is the $4 word for this is anisocoria when they are when they are unequal pupils. So this top one, some people actually have that by nature. That is what it is. When you look in somebody's eyes, there is a potential for people to have two different color eyes, like a husky, like a dog. That's actually a thing. But this is an abnormal finding unless they tell you that that's part of their history. So generally speaking, people should be equal round and equally reactive to light when you shine in them. And understanding that's really all you got to do. Moving to ears, there's a couple different parts of the ears. If they have some kind of blunt force trauma to the outside, if it's more of a shearing issue to the ear, where they've just damaged the outside tissue, there's probably no issues whatsoever. If it's a direct blow to the side of the head, that's where the problems can come in. There's the potential to damage all of the outside. Let's see if I can go to. No, there's not a good picture. If I go to if I take direct blunt force to the side of the head and it hits the ear square. If there's an airflow that stops, if it's a full occlusion of the ear during impact, that can rupture the membranes on the inside, and that can create a significant inner ear injury. Blasts, any kind of explosions, stuff like that. That's all what we're looking for there. The other side of it, if it's just tissue, again, you can't really do anything about it. If somebody Mike Tyson's their ear and part of it comes off, really all you can do is bring it back to the hospital with you. No life threat, nothing I'm worried about. What I will say very, very specifically about ears, if there's fluid coming out of the ears, that is no good. So any kind of blood from the ears, from the inside of the ear cavity. Now we're not talking about the Tyson bite. We're talking about inside the ear. There's some kind of bleeding coming. That is some kind of damage to the skull that's allowing blood flow to seep into the ear cavity or ear canal and leave. That's no good. So blood is no good. What's worse than blood is cerebral spinal fluid. So if there's an impact that somewhat allows the connection between the cerebral spinal fluid to the outside ear to the point where you're leaking cerebral spinal fluid from the ear, you don't have to be a doctor to know that's a problem. What you have to do is you have to be able to identify that. So if there's no way to pack that, you can't stuff a bunch of gauze in there and stop the bleeding or whatever. You just have to kind of let it just tilt their head to the one side. If you can, they'll probably be on a backboard because they had some kind of trauma. Try to get them tilted to one side if you can to let that kind of drain. If it drains and you take a 4x4 and you stick it underneath the ear and a drop of something hits that 4x4, we know what blood looks like. Blood's going to be red or kind of a dark red, maybe even kind of a weird purple color if it's super like close to the hard venous blood, but it's going to be that dark red color. If you drop something out of the ear onto a 4x4 and it looks like a halo, so there'll be a dot where the actual drop hit, and there'll be this halo or a ring effect that kind of goes around it. That is the hallmark of cerebral spinal fluid. So they call it a haloing. So that drop of blood on that 4x4, if it's not blood, if it's a clear fluid that has that ring around it, that's that cerebral spinal fluid. That's a really, really sick patient. So, and they're probably not going to be super conscious and alert and able to deal and talk with you. So that's really the only thing for ears. So again, drainage is really where it's at, because again, that some of that, anything coming from the ears, again, that's no good. Jumping into the nose in general, the whole job of the nose is to humidify the air that comes into the lungs. That's really, it filters and humidifies. That's the job of the sinuses. That's the job of the nose itself. So we know that there's all these different channels that kind of run up through the nasal passage. And again, a lot of that has to do with where the olfactory nerve ending is, which is kind of up in the very top, the superior area. Up in here is where a lot of that olfactory system lives for smelling. If there's damage to the brain or to the bottom side of the eyes, this can all be swollen and affected, which is why we're concerned about them not being able to smell, because there's something pushing on this top part of the nasal cavity. So we also know something else that we're going to be doing is with the congestive heart failure patients, with any patient that needs an advanced airway that's not conscious or able to open their mouth. For example, I had a real bad car wreck a couple years ago. The female, she had trismus, which means her jaw was locked shut. I could not open her jaw for anything. So with patients like that, you need an airway. She wasn't breathing, but she was clenched down. So the only two ways you can do an airway is either a surgical airway, which is ultimately what I did, or a nasal intubation, which is sticking the breathing tube up through the nose and down in through the trachea. But if you look at this, that's not a super easy process. If you look at the anatomy of the nose, the intubation tube has to go up, and it has to make that hard 90-degree bend to go down the back of the trachea. That's a pretty tough thing to do. It looks a lot easier here, but this picture is an expanded view. So the nasal cavity is not necessarily that big to be able to do that. So you'll learn how to do that. You'll physically demonstrate that, and you'll be able to do a nasal intubation. But again, that's going to be kind of a difficult thing to do. So, but anyway, this is generally the nose. Really, it's humidification or humidifying and filtering the air that's coming in. So with the nose, you look for general stuff. This is all cartilage. There's not really any bone in here. The only bone is where it connects to the face up towards the top. So there can be a lot of tenderness. There can be swelling, and a lot of it's just cartilage. It's not necessarily anything that we can treat. So looking at the throat, we're looking for, again, that patent airway. That's all I'm looking for, some kind of obstruction. Again, with an adult, the test question is usually, what is the most common airway obstruction in an adult? And the answer is the tongue. The tongue is monster, and it actually takes muscle rigidity to keep that tongue away from the back of the pharynx there. So somebody that's unconscious laying on their back, their tongue is naturally going to relax and flop over the epiglottis. It's going to flop over the top of the airway. So that's going to be the number one airway obstruction for adults. So I only care about this for unconscious patients, and I care about this for like seizing patients that can't maintain their own airway. That's why the oral pharyngeal airways are so useful, because those OPAs go in there and they keep that tongue down at the bottom of the mouth where it belongs. Teeth are another big one that, when you're looking in the mouth, look for obstructions. You're looking for teeth. You're looking for displaced dentures. You're looking for, whatever. We had a lady, God love her. She, I think 7 was the ultimate number before she either died or disappeared, but she would choke on hot dogs. And for some reason, after the first 6, she didn't get the hint. And literally there were 7 runs that we made where she was literally full obstructed airway, choking on a hot dog. I had her the one day that she decided to go eat healthy. Instead of hot dogs, she got a piece of broccoli stuck. So we had to go in there and try to get that out. But again, looking for an airway obstruction, that could be a good indicator why somebody's not breathing. So put yourself in a run. So tones go off. You got a patient, you got a non-breather, and it's whatever. It just run of the mill house in your areas. So you're going there, you're on your way. All this stuff's going through your head. Cardiac event. Why are they old? Is this like an elderly patient? Is this, whatever? Why do people die? Well, some kind of shock, some kind of cardiac event. So you get there, and on the floor, you find this person laying on the floor, and they're not breathing. they're a complete non-breather. So you go into hero mode, and you and your crew, you start doing chest compressions, and you start doing airway management, you start doing all this stuff and checking all the boxes for that particular run. As a medic, you've got all these other things now you're worried about. What cardiac rhythm are they in? Do we have an IV or an IO? What medications are up? What do we do for? Do we give epi now? What are we doing now? Somebody's doing documentation. At some point, it's easy for us to overlook it, but this whole patient, this whole run maybe isn't a cardiac event. This easily could be an obstructed airway, a choking issue. And literally just by oxygenating the patient, they can absolutely come back if you find it, if you notice it. So when we say, when you give the breathing, when you breathe and you check and make sure you actually have chest rise and fall, that's a huge deal. That's a huge deal for a lot of reasons, but specifically this. If they've aspirated something and their choking led to hypoxia, and the hypoxia led to their current situation, then that's a preventable thing. That's a treatable thing, as long as it's within 4 to 6 minutes or whatever it is, that the brain can deal without oxygen. So again, just get in a habit of when you're doing your assessments, don't just default to, oh, this is a non-breather. I've seen it 15 times already, and we're just going to do this thing and maybe we'll call it in the field. Don't think like that. You have to think of the causes. Think of why. The why is what makes you a paramedic. That is truly what's going to make you a medic. You may not know why, but that's okay. We have to start trying to question that, though. We have to try to figure it out. I, to this day, still make runs. I drop them off at the hospital and I go, oh my God, what the hell just happened? I have no idea what just happened. I don't know what was wrong with the patient. Literally, I was just chasing symptoms. They weren't breathing. So I breathed for them. It's like, oh, they came back to life. Cool. We're good. Check a blood sugar. That's a mess. Well, cool. Well, we'll fix that. So I fixed that, and then they stop breathing again. Like, it's truly just chasing these symptoms back and forth. And at the end of it, I just shake my head and go, I got nothing whatsoever. So we need to make sure that we are doing stuff a little more systematic, and we're thinking about the why. And once you get into that, that's truly what differentiates a new medic between a new medic and an inexperienced medic and a good medic, is really being able to figure out the why, and at least try to think through the body system and kind of what can be creating this. How can we reverse it? How can we intervene? That whole thought process is truly what makes a medic a medic. Lips, gums, skipping through a lot of that. Throat, tongue, I don't care much about any of that. You guys are going to know ugly when you see it. The neck. So the neck, there's a lot of stuff that lives in the neck. We know there's a lot of vascular system. We know that there's some endocrine stuff. There's some glands. There's, obviously the obvious stuff. There's the esophagus and the trachea and the spinal cord and spinal fluid. And, there's cervical spine processes in the back. So we want to make sure that they're even. We want to make sure there's no masses. Again, if there's a mass, that doesn't typically happen overnight unless it's direct impact or swelling or something like that. So they're going to know that they have cancer or they have something. There's something there. That's not going to be a new finding. Venous distension. We talk about that in class, where if you're looking at them in the one side, they've got their either their carotid or their jugular vein is distended. We know that that's not good. We know that if there's one over here, we'd want to see them on both sides. You'd want to feel the pulses. If there's not a pulse on one side, that's a problem. Things like that. So with the neck, and there's a lot of other stuff that we're going to do. Surgical airways, they live, the landmarker for that lives right in the center of the neck. So there's a lot of that stuff that we have to be able to identify as we're going through our treatment, just in case we need to find that stuff later. So we talked about the cervical spine. Again, C3, 4, and 5, that keeps the diaphragm alive. That keeps them breathing. If there's any kind of insult up here in C3, 4, and 5, that affects the brainstem. And if the brainstem's affected, so is their breathing. So that's all a problem. Again, if you can palpate the back of their neck and you can feel down and you feel something poking out that doesn't poke out anywhere else, then we know that that's probably an issue. That's a good indicator that we should probably put a C-collar on a patient. And again, this is just kind of review of our basic head-to-toe assessments. Again, it's the head-to-toe assessment, but it's applying a little bit higher level of thinking to the why. So why do you put a spinal mobilization? Why do you put a some kind of cervical collar? Well, if you're touching the back of their neck and it hurts, then they probably need a collar. If you're touching the back of the neck and you feel some spinous process or something poking out, you might not even be able to articulate that. Just, I feel this big notch that shouldn't be there. Well, that's probably part of their C spine, or one of their cervical spinous processes. You should probably put a collar on them. If they're altered, if they've been thrown from the vehicle, if, all of that stuff, there's specific inclusion criteria for that. And a lot of the departments have, a lot of your departments will have something very specific for that. But so you go down, you just feel down. If they have numbness and tingling when you touch their neck, that's probably not a good idea. That's probably not awesome. You could probably right now, if you've ever been to a good massage therapist, if you push hard enough, you can make numbness and tingling happen in your fingertips. If you hit specific pressure points or spots, that's not abnormal. But if you're touching their spine, when somebody goes down your actual spine and pushes, you shouldn't feel any discomfort unless they're pushing hard enough to create like tissue pain there. You shouldn't feel numbness and tingling. If so, that's a problem. That is a patient, when you're feeling the back of their neck, if they complain of something weird, all of a sudden they get hot, or that hurts real bad, or all of a sudden they get cold, or there's tingling or numbness. Those are all indicators that there's some kind of issue. You're pushing on something that's broken, or something that has some type of problem. We have to be real careful not to like manipulate it. Because again, if you're pushing hard enough to create that paresthesia or that numbness and tingling, then you're pushing hard enough to create additional insult or damage. So we got to be real careful about that also. And then as far as like range of motion and stuff, a lot of that I'm not a chiropractor. I'm not a doctor. I don't want to assess their range of motion. If they're up walking around the scene when we get there, to the car wreck, then, I can document that they were up, they were ambulating, they were walking around the scene. But again, I'm not in the business of trying to put them in a wheelchair forever. So I'm going to let them, they're going to do what they're going to do, but I'm going to try to tell them to keep a midline in their neck. I'm pretty sure that's something we would all do. So the chest, all kinds of important stuff live there. We've talked a lot about this in EMT school. But now again, digging a little bit deeper, there's the chest wall. So essentially the actual surface, the skin, the bruising, contusions, to an extent, the ribs, the flail chest segment, and that is about where the EMT school stops. So pulmonary evaluation, moving a little bit deeper into the realm of the chest, you're going to listen to lung sounds. Are they equal? Are they the dirty phone call Kussmaul's? Are they regular? Are they deep enough to support good oxygenation or respiration? So what kind of quality of breathing are they having? Are they just panning? Are they very, very just short and shallow? Because that's not effective either. So we're looking at the actual ventilatory pattern. We're looking for capnography. Capnography, again, we know from the other day, that is exhaled carbon dioxide, or the exhaled acid coming out of the body. So I can quantify that. I can say, I can put a definitive number to that that I can potentially treat based on. So that's pretty much the pulmonary evaluation from the chest. And then there's the cardiac, which again, rate, rhythm, quality, all of the stuff that's related to the cardiovascular system. And I don't want to go too deep into that, but that's this is basically what we were talking about. We're looking for, this is the outside. We're checking for the any kind of decap BTLS, on the chest. Moving to the lung sounds, which is what we talked about. The advantageous lung sounds down there at the bottom. These are going to be pretty important for us to be able to distinguish the difference between. So just kind of running through some of these. So normal is what you would normally hear in yourself. If you don't have your own stethoscope, next time you're at the firehouse, try this. Just figure out what a baseline is. And be the weird creeper that asks your crew to listen to them. Most of you probably won't do this, but I can't tell you how beneficial that is. If you have somebody that's a smoker on your crew, specifically not an elderly, but an older person that's been smoking their whole life, I challenge you to listen to their lungs, because it's going to sound different already than yours. So tracheal sounds, by definition, tracheal sounds are kind of a loud, harsh. They just sound really just kind of raspy. And again, you can YouTube these, all of these lung sounds. There's thousands of videos on YouTube with different lung sounds. And again, I would challenge you to kind of know some of these. Specifically, the ones I'm worried about are the ones that have to do with fluid and the ones that have to do with wheezing. But to be able to identify those two, you have to be able to know what normal is to know what normal isn't. So to be able to figure that out, the bronchial sounds is kind of a high pitched. You can kind of hear it. It's a higher sound. Again, I wouldn't worry too much about that. I certainly wouldn't worry about the vestibular is not something I'd worry about either. The big ones that I need you to know normal, and I need you to know the bottom ones. So wheezing is a very, very distinct high pitch. It's kind of a high pitched whistly kind of noise that happens low in the airway. That is your asthma patient. That is your COPD patient. That is your inhalation damage patient. What you're hearing there is those alveoli, those little air sacs, have collapsed, or they're being completely surrounded by swelling in the tissue that prevents them from physically working. So what you're hearing is the air go over the top of those little channels that have been swollen over or collapsed. So you're literally just hearing the air move around those air sacs, as opposed to actually going into them and being able to allow respiration to happen. So wheezing is the high-pitched whistling. Again, that's asthma, that's COPD, and that's some kind of toxic inhalation trauma to the alveoli. Crackles, which is also called rales. So rales and crackles are synonymous. Those are the same thing. And that's just wet sounds, wet lung sounds. If you listen in there and it's kind of just, it just sounds wet, and it's hard to explain other than it sounds wet, a little bubbly. Usually it happens, at the very end of their exhalation cycle. So at the very, very end, you'll hear kind of like the bubbling kind of happen. Those are rales. Those are so normal is the most common, and in order here is about what you're going to hear as far as runs are concerned. Most patients will be normal. Those that are not normal, a high percentage of them will probably be wheezing because they've called for asthma or COPD or something. And then after asthma, the next common finding would be rales, where they're just wet, and that could be like a CHF patient. That could be a COPD patient, but just kind of like I said, just generalized, just wet. Rhonchi is kind of a rattling noise. So when they exhale, you'll hear like popping, not bubbles, but it's more of a defined, it's a rattle. And again, there's plenty of awesome videos on YouTube, and I might find one and post one in Schoology. But in general, you'll know the difference between rales and rhonchi. Rhonchi is a very, very coarse, again, it's just a really, really heavy, nasty breathing pattern. And again, rales is just kind of that little light bubbling in there. Stridor, textbook, test question, National Registry, stridor will be a very, very common thing that you're going to see moving forward. Stridor 100% is an upper airway obstruction. It's something that's blocking the airway, and it creates a whistle when they exhale. It's like a whistling noise because it's air trying to move around that obstruction. So stridor is going to be a very, very important thing for you to be able to identify. Pleural friction is like it's this grating noise. So that grating noise is the actual liner that goes around the lungs, that whole pleuritic cavity. There's some kind of swelling. The lubricant, the surfactant that lives kind of between there, that kind of lubricates the inside lining of the lungs. Some of that is kind of like I said, it's either inflamed or there's infection. There's white blood cells or pus or something in there. That pleural friction, that rub is, again, it's your fingers rubbing together. That's what you would hear in your stethoscope. So again, really important stuff right there. Please commit that to memory. Any questions on the lung sounds? Please ask them if you have them. Hearing none, moving on.
I did have a question on the rhonchi.
Yeah, thanks.
It's fluid in the larger portions of the lungs, correct? Where would you see that pathophysiologically speaking?
CHF. You'll hear CHF, pneumonia where there's actual fluid. Usually the rales, what happens with the rales is fluid kind of settles. And again, I use the 2-liter bottle because it's the easiest way for me to remember that stuff. If I took a 2-liter bottle and on the inside of that, I said the entire inside lining of that 2-liter bottle is the important spot for your body to actually draw oxygen out and get into the bloodstream. If I hold a 2-liter bottle up and I put, half a cup of water in the bottom of it, that bottom is essentially useless. There's no air that's going to get through the water and into the alveoli down in that base. That is your pneumonia patient. That is exactly what happens in the pneumonia patient. There's some type of buildup or fluid or something that lives down in the very bottom of the base, and it sits there and just festers. When it festers, it swells, and then you end up with this pneumonia, which is essentially an area at the very base of the lung that's no longer usable for oxygen until that infection goes away. With the CHF patients, they're the congestive heart failure patients that have a backup, so their heart's not beating enough. On the left side of the heart backs up. It backs up to the lungs. All that fluid has to go somewhere, and that all starts to accumulate in the lung and around the lung tissue. If I took that 2-liter bottle with that same fluid and I turned it on its side, that whole back wall now of the 2-liter bottle is it's not usable. Now, if I took the 2-liter bottle and I flattened it, and I did it, it would be even worse. And if you think about the lungs aren't around 2 liters cylindrical item. They're more of a flat, there's more surface area. So if I lay it flat, you're essentially losing about half of your lung tissue to that fluid. So rhonchi is basically that diffuse. Every time they breathe, it literally sounds like they're underwater. Where rales at the end or the peak of their exhalation, you'll hear like a little bit of bubbling. If you have bronchitis, anytime you have bronchitis, there's a little bit of swelling in the bases of your lungs. That bronchitis, you can usually, if you exhale forcefully at the very end of that, you can actually feel like a little bit of popping. And I think it's hard to explain, but I think most of us have probably had that. That is rales. But if you took a deep breath in and literally it sounded like you had water in your lungs, like literally bubbling through, it sounds like they're literally drowning. That's that really, really coarse rhonchi that I'm talking about. Pretty ominous is really what it is. It's pretty scary. So that's kind of the difference between those two. And again, YouTube videos, and there's hundreds and hundreds and hundreds of them differentiating specifically rales and rhonchi because they kind of live together. So just the difference between rales and rhonchi, you can get lost for hours watching those videos. We'll do a few more and we'll take another quick break. This is just where you're listening. Again, we see that the lungs, they're not quite the 2-liter bottle that I was explaining. So, again, if the bases of the lungs are filled with fluid and you lay them down, now the whole back of the lung is filled with fluid, and that's clearly a problem. That's why people that are sick, sitting up, being propped up, a couple pillows behind them, that's a pretty important thing to understand, because what they're doing, they cannot breathe when they're laying flat, because again, it's that fluid's taking up the whole posterior side of the lung, and again, that's no good. So I think the next slide's a little bit better even to talk about. Yeah. So again, that nocturnal dyspnea, that's a term for somebody that at night while laying down has a hard time breathing. So nocturnal meaning night, and dyspnea meaning trouble breathing. This is exactly why. So your congestive heart failure patients, which I like to go back to them because they're a very cut and dry class of people, but they will literally sleep propped up so that fluid that's in their lungs stays down towards the bases, so the most tissue is open and available as possible. So if you ask them, a very, very important clinical finding for them is, how many pillows do you sleep with? That's a very important question that I do ask for the congestive heart failure patients. Do you sleep with pillows? How many? Because if they need 4 or 5 pillows to sit virtually propped up almost in a Fowler's or a semi-Fowler's position, then we know that patient's got a significant accumulation of fluid. If they just need 1 or 2 just to kind of get their head and kind of their upper body started, and that's good enough for them, then they're probably in an early stage. So, that's it's just kind of a little trick that I try to use. And the textbook does talk about a little bit, being able to sit them up a little bit. So in this particular slide, it says rhonchi there. Again, coarse, kind of low pitched. Again, it's literally like you're listening to somebody that's breathing underwater, is what that sounds like. And then skipping down. So again, stridor. Stridor. If you look at stridor, so we know that's generally that's an airway obstruction of some kind. If I took my stethoscope and the higher I got in the bronchial tree, the louder this should get, because again, we know that this lives in the upper airway. That's where we're hearing the noise from. So a stethoscope on the side of the neck, that stridor should be way louder than if you're holding down somewhere low in the base of the lungs. So just kind of keep that in mind when you're trying to differentiate. That stridor, not only like an upper airway obstruction, but there can be some kind of swelling in the tissue. There's a disease called epiglottitis, which I think we remember from EMT school. But epiglottitis is the swelling or inflammation of the epiglottis, which again is back here. You're going to end up with stridor. And there's some things that we can do to kind of help that, but we can't necessarily treat that because we have to get rid of that swelling. If you go all the way to the bottom of the left, there's crackles. Remember, crackles and rales are the same thing. Again, it's just kind of fine crackling. It's if you close your eyes and put yourself by the bonfire, if you hear the crackling of the fire, that is kind of that crackling that they're talking about. It's just that it's just little tiny light popping. So rales, rhonchi, and wheezes are the ones that I'm really after. So, and stridor, of course. So kind of keep those fresh in your brain. So chest, we just talked about that. Cardiovascular system. I think that's probably a good spot for a quick break. We don't have a whole lot left to go. So we'll finish this up. Like I said, make sure between now and when we're done with this, have a piece of paper, have a clean notebook or something that you can set aside. Because I'm going to give you some math formulas for again, that's what we're going to close out with today is some math formulas. So just like I said, have something to write on, have something good there, and we will be back in about 5 minutes or so. All right, hopefully I'm not losing anybody in any of this stuff. Hopefully this is all still somewhat review with a little bit added. All right, cardiovascular system. I think we talked a lot about that already. So I'm not going to spend too much time in that. The two circuits that the textbook likes to talk about is basically the body, the entire body, the bronchial tree. So perfusing the actual bronchial tree. And then the third one that it's not mentioning here is the cardiac system. So again, the coronary arteries. And you can individually assess those individually based on, again, lung sounds and blood pressure and, things like that. So we talked about this before. So this is kind of in a reverse order. I would start at the bottom just for memory purposes. Contraction or squeezing is systole. And then there's diastole where it relaxes, and when it relaxes, it refills, and then it starts over again. So that's the general cardiac cycle. I think the way you understand it already, if this is a little bit different than that, don't put too much effort into this. So again, squeezing, relaxing, that's the big thing that we're kind of paying attention to. So this right here is heart sounds. Again, the book does a really good job of kind of explaining heart sounds, but and in general, you probably won't ever really be able to appreciate this, even though the book says you probably should. In general, just kind of a breeze through. When the heart squeezes for the first time, that's the first sound that you can actually hear. They call that the S1, or it just sounds kind of like the first. If you sit and listen to your heart, you can the first noise that you hear is exactly that. It's that S1 sound, which is basically closing the ventricular valves, and basically that noise of that closing is what you're actually hearing with the heartbeat. The second, or the S2, is usually louder than the first. That is the finalizing of the ventricular squeeze. So again, none of this really matters a whole lot for us in true theory. There's nothing we can really do to change or fix this. So when they talk about S1 and S2, they're just referring to heart sounds. That's pretty much at the core what we got to know about that. This is still more about the actual heart sounds. And again, there's a lot of this stuff that really goes in deep into theory that I'm not super fond of even going over. Because again, we're not necessarily going to we're not going to worry too much about that. Korsakoff sounds, again, that's 100% related to the strength of the contraction, and it's all tied to blood pressure. And again, I'm not too worried about that. What I am worried about are these. So a bruit is a whoosh sound. That whoosh sound that they're talking about here, this is actually part of a neck evaluation. So in the carotid arteries, if there's a bunch of plaque and buildup in there, sometimes you can take your stethoscope and you can set it right over the top of the carotid, just light pressure, and you can actually hear the whoosh. You can actually hear the blood flow pushing past like a blockage. So those bruits are it's a pretty important finding if you're hearing whooshing sounds coming from somebody's carotid arteries. So bruits are pretty important for us to be able to identify if we heard that. And a heart murmur is exactly the same noise, but it's heard over the heart, and that's basically the bicuspid or the mitral valve not closing all the way. So if that valve doesn't close all the way, you're going to hear that whooshing sound kind of come from the small opening that still exists when it's supposed to be closed. Does that make sense? Those two specifically? All right. And I skipped over the top one. An apical pulse. An apical pulse is really, really important for us to be able to understand. And I kind of take for granted that we did that in EMT school, but I don't know if we did or not. That's physically listening over the heart with a stethoscope. That's just a fancy term for that. So somebody that you can't feel a pulse on, but you think they actually have one, or the monitor shows one, put a set of ears on and just hold over the heart and see if you can physically hear the heart. If so, you can count a pulse rate and stuff like that through the apical pulse. I don't want to go over. We pretty much covered this. You can feel a pulse on systole. So if you hold your radial pulse, every time you feel a pulse, that is the systole contraction. That's the squeezing of the heart. You'll feel that there. Jugular vein distension. We'll talk a lot about this in trauma, but that's the swelling of the jugular veins. And again, this is all part of the cardiovascular system inspection. So again, taking a few steps back, this is the car wreck patient that you're trying to figure out what the hell's going on. What is the most critical, or what is the biggest life threat here? And this is, we've identified that, head to toe, there's nothing really significant. There's no cervical spine issues. We've assessed breathing, and they're breathing fine. Now we're assessing cardiac. And if cardiac is kind of a miss, then this is us digging deep into that. So again, you're going to listen to heart tone. You're going to listen to the heart, make sure you actually have a good heartbeat. You're going to check a blood pressure, because again, that's tied to cardiac output. You'll look at the jugular veins, make sure that they are not swollen, or, make sure there's no problems with that. Make sure you don't hear any bruits, which again would be a blockage of some kind. If somebody had a seatbelt that was inappropriately, specifically kids, if the seatbelt was inappropriately worn, traditionally, backing up a sec, a seatbelt is supposed to come out somewhere right above the shoulder, and it's supposed to go mid-center, mid-clavicular, and it's supposed to go down and obviously connect where it does. A lot of kids, if they're not in a position, like in a belt positioning booster seat, a lot of kids, it will come from up here, the seatbelt will. That's the point of a booster seat, is to bring that seatbelt down to over the shoulder. So if a kid's wearing a seatbelt incorrectly or up high, there's a potential that they can take an insult to one side of the neck to the point where it could damage the vascular system there. And that's what the bruits from the last slide, that's what you're listening to. You would want to listen here to make sure you don't hear that whooshing or that collapse in that carotid artery. This is so jugular vein distension. The next part of this for the elderly patients is some of these are, I like to call these are just comorbidities. These are some other things that create a problem that doesn't help their current situation. So if they're a diabetic by nature, they're going to have poor peripheral perfusion. They might be on some kind of beta blockers. Now, again, back to the email I sent, a beta blocker is, we know that anything that ends in LOL, like metoprolol or atenolol or any of those are beta blockers. The whole job of a beta blocker is to regulate blood pressure by decreasing the heart rate. So it slows the heart rate down a little bit, and it slows the contraction of the heart rate, and it loosens that up. So knowing that it's a beta 1 agonist, we know one heart. So beta 1, that's what a beta blocker is. It's an antagonist. It's a beta antagonist. So it basically tells the heart to stop beating so hard. It blocks that receptor site. So beta blockers, that's exactly what we're kind of concerned with here, because they're not able to compensate. So where their pulse should be high, it's not going to be. They're not going to be able to compensate because there's a blocker that's blocking the heart's ability to do that. Normal blood pressure, we went through that. Moving forward, we talked about that. So the abdomen, the abdominal cavity. We know that there's 4 quadrants to the abdominal cavity. They, in general, we know that the diaphragm kind of lives in the separation between the top and the bottom. We're going to we'll palpate all 4 quadrants, and within those 4 quadrants, this is showing 9. Realistically, we're just going to typically have the 4. There's the upper left, upper right, lower left, lower right, and based on that, if there's tenderness or swelling or pain on palpation, that's something that we document. That's about it. Abdomen, I don't want to go too deep into any of this stuff. Any questions on the abdominal cavity? We know that a lot of stuff live in it. We know a lot of different types of organs live there. We know that any pain or any swelling or any distension, and distension just is the technical term for like swelling or firmness. Any of that stuff we know is not good. So that's really kind of what we're looking for there. Making sure I don't have anything else for that. That's really it. So this is kind of important to know. This is important to know for a lot of different reasons, but specifically they've tied it to the abdomen, but this really applies to everything. Visceral pain. Visceral pain is the most significant. It's a very, very sharp, very, very hyper localized. If I broke my shoulder, if I push on my shoulder and it hurts, it's going to be this shooting, stabbing, this visceral, god awful pain. And then, from there, inflammation can kind of cause some dull, achy kind of pain, and then referred pain. Referred pain is, if I've hurt my shoulder, if I push on this shoulder and it makes this shoulder hurt, that's a referred pain. It's pain that's felt elsewhere. That's pretty significant with cardiac, specifically with women and specifically with elderly women. A lot of times a cardiac event can be manifested as pain in like the jaw or the neck, sometimes even the back. So if there's an elderly person telling you, specifically an elderly female, telling you that her jaw hurts, that could very well be a cardiac event, or a shoulder pain. That could absolutely be a cardiac event. And we'll learn later that could also be some other things, like gallbladder has referred pain, because gallbladder itself, that organ doesn't necessarily have its own nerve endings. So pain or swelling there is actually felt elsewhere. So we'll kind of get into that later. Any questions about any of this stuff? Probably not. It's pretty straightforward. Orthostatic vital signs is basically you take a blood pressure while they're laying down, and then you take a blood pressure while they're standing up. Essentially what you're doing here is you're testing that alpha receptor site system. If they're laying down, everything's calm, you should get an accurate blood pressure. If they stand up, the alpha system, those alpha receptor sites are supposed to say, hey, we're standing, I need to increase the pressure, and they'll constrict the blood vessels. That allows a greater pressure so that it can fight gravity to go up and down while you're standing. If that system's broken, orthostatically, they'll stand up and they will pass out because blood flow never made it to the brain. Or they'll stand up and their pressure will be in the toilet because, again, the alpha system's not constricting the way it's supposed to. So there's either a fluid problem or it's that alpha system that's not working appropriately. And again, this can be a sign of dehydration. This can be a sign of some type of shock. And this could all be, you could be called for, something like nausea, vomiting, diarrhea, flu-like symptoms, syncope, all of that stuff. And this could be the underlying differential diagnosis for you, is that they're just orthostatically hypotensive. So they stood up too quick or something like that. So here's the official definition of a positive orthostatic finding. And basically you have a decrease of up to 20 points on the systolic, or an increase of 10 on the diastolic. So these are basically what you're doing here is, again, this is just you've taken it while they're laying down, you take it while they're standing. And if there's a 20-point difference in the systolic, then you know that there's a problem there. There's a positive finding. Moving through. The one thing I see on this slide that's important, the pulsating. Anything you feel, if you feel somebody's stomach and you feel a pulse in their stomach, no good at all. In the ambulance, got to go. Usually what that is some type of aortic aneurysm. And every time the heart beats, you can feel that in the stomach, that abdominal aortic aneurysm, or AAA. So again, no good. Don't go poking and prodding on that too much, because that's a water balloon you don't want to break. So that lives somewhere close to the stomach, because is that aorta, the swelling doesn't really have anywhere to go. The abdominal cavity is a puzzle as it is. It's fit together just so perfectly that, you know, anything that's abnormal, a tumor, a mass, a bulge, some type of aneurysm, it doesn't sit well. So the body tries to let that fester out, and occasionally you'll actually feel that on the anterior side in the stomach, because again, everything else is said, we're going to push you kind of out of the way because you're affecting everything else. So feeling something that pulsates, don't poke and prod on that. That's not going to be super good. Ascites is just fluid under the skin. You may feel that somewhere like around, like if you have some kidney issues, you may feel that around the retroperitoneal space. Typically you won't feel this very much at all. You'd be able to hear it if you percussed it. And again, we talked about how percussion is not really going to be a thing for us. So I wouldn't worry too much about that. What I would worry about is the next one. So periumbilical, which is around your umbilical or around your belly button. There is the possibility of this cyanosis color that happens right around the belly button. They call that a Cullen sign. Write that down. That's important. So a Cullen sign, if you're looking at the stomach and around the belly button, it's kind of bluish, or some flavor of cyanosis around the belly button. That is a Cullen sign. That is a significant impact to the stomach. You'll see that occasionally with again, seatbelt marks. So we know that the upper shoulder strap goes down over the mid-clavicular line and connects, and then the lower abdominal strap, that part of the belt that goes over the pelvis. If they wear that a little too high and they get in a front end collision, 100% of that force gets transferred into the stomach. There's a whole lot of bad stuff that can happen there. So if you expose the stomach and you see this Cullen sign, that's no good. Likewise, if you get this bluish or this discoloration along the flanks, that's a Gray Turner sign. That's another big deal. So they're both the bluish discoloring, but the Cullen is around the belly button and the Gray Turner is around the flanks or the outsides of the body. The Gray Turner sign is typically associated with an ectopic pregnancy, so you'd see that in a female. And the big indicator for you is that this probably wouldn't be a trauma patient. So you would get called for abdominal pain or severe abdominal pain. And you would get there and you would expose and you would look, and this could be a finding of that ectopic pregnancy, which basically is this pregnancy that happened in a fallopian tube, and either there was a burst or some kind of perforation, or there's some other type of blood flow that's going under the skin. So Gray Turner and Cullen sign. Again, the way the questions would typically be worded is it would be something along the lines of your patient is presenting with a Cullen sign, or I'm sorry, your patient would be, they're presenting, you find a Gray Turner sign. What is this most likely indicative of? And these would be the answers, ectopic, abdominal trauma, something like that. So ectopic pregnancy and Gray Turners typically go together. The Cullen sign can also be, both of these can both be for the ectopic pregnancy. They could both be for, they say acute pancreatitis, which that is what it is, but I'd be more focused on the ectopics and the direct abdominal trauma. So I say this because, again, yes, you got to know it for the test, but regardless of in 5 years, if you guys remember what these terms are, if you expose somebody's stomach and you see bruising around the belly button, regardless, you're going to know that that's a problem. And that's kind of the goal here. So you're going to try to listen over the abdomen. You're going to hear stuff because you'll hear bowel sounds and gurgling and burgling and stuff like that. You should always hear that. The epigastric area, which is right where, right at the very, very top of the stomach, we'll listen a lot to that area specifically for airway. That's kind of the stomach area. If I put a breathing tube in, if I intubate somebody, I should hear lung sounds over the lungs and nothing over the epigastric area. Because if I hear breath sounds in their epigastric area, then somebody intubated the esophagus and not the trachea. So it's in the stomach and it's not in the lungs. So that's the key reason that we're going to listen to abdominal sounds, is to look for that epigastric noise. So again, that's related to airway. This is not necessarily related to airway. They're talking more about trauma and the medical patient here. But really, there's not going to be a reason to listen. They'll tell you that if you listen, you can potentially find like hyperactive bowel sounds or hypoactive or absent, and that could all indicate like a bowel blockage. Again, not an acute problem, and it may be, but it's not an hour problem. It's a hospital problem. So we'll push on each quadrant. The number one mistake that medics make is that we don't push hard enough. So we should push hard enough that in a normal patient, it should elicit a little bit of pain. It should be uncomfortable. If you're pushing that firm, they should know that you're pushing. Again, it's generally uncomfortable, but not painful to the patient. If they scream at you because it's painful, that is the positive finding that we're looking for here. So guarding is just them saying, hey, that hurts, ow, 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 stop. Or they withdraw from you. That's a problem. Rebound tenderness is a really, really important concept to understand. If I push down and I let go quickly, that rebound, if that becomes tender, that can be a problem. In fact, that's going to be the number one way that we identify some kind of appendicitis in the field. There's a specific spot in the stomach that I'll teach you. If you push down, it's not going to be super painful, but the second you let go, they come off the cot. That is a really, really, really solid indicator of some kind of appendicitis. So rebound tenderness is letting go and that pain starting. Abdominal rigidity, that is sort of what it is. Give me just a second here, sorry. If you're not here, say aye. I think we lost somebody. Okay, that's okay. They'll catch up. All right. So again, we talked about that. Moving on. Ribs. Yeah. Feel the ribs. Don't go too crazy in that. Just have them take a deep breath. Does it hurt? Yes or no? That's really what I'm concerned with. Do you feel a bunch of crepitus? Yes or no? Gallbladder, again, I'd prefer you not reach in and try to poke somebody's gallbladder. Again, you're not going to be friends anymore. I wouldn't be too super worried about that. And you're not going to be able to find the under liver edge. Like that's just not really a thing that you're going to be able to find. So again, 4 quadrants, palpate it. If you have tenderness when you push, or it's really firm when you push, try to figure out which quadrant or quadrants are firm and then document that. If you have rebound tenderness, document that. Most of the time, these patients they're gonna scream at you anyway, and you're not gonna have a super awesome clinical finding out of any of this because they're just generally not comfortable. That's why they call 911. Yes, you can move around the left side, like move around the rib cage and try to poke and prod on the spleen. Let me tell you a secret: you're not gonna do that. Moving on, aortic aneurysm, super important. This is a life threat. This is something they're gonna die right now. If this thing does burst, they are dead, literally in front of you, and there is nothing you can do about it. So this is super, super awful. These patients, when they're calling 911, they either know that they have this and they're living with it, which is not uncommon, or they don't know they have it. They don't know that they're living with it, and by the time you've got to them, it's this undiagnosed thing that we have no idea how good or bad it is. If the patient, I've had a couple of these, if the patient has been discharged from the hospital with one of these, then it's because it's not bad enough that they want to go in there and risk surgery to benefit potentially preventing the collapse of this thing, or that they're just too elderly and comorbid to be able to do a surgery safely. So one of the two, if you're going to see these in the field where they know that they have it, but either way, they're going to be sick. So when they contact you or when they call 911, they're going to be shocky. They're going to be cool, pale, and diaphoretic because a lot of the blood flow is trying to fight through this little swale or this little bulging, this little bulging on the side of the aorta. So sometimes you can feel that pulsating mass because, again, the body tries to fester stuff out. If you get a splinter, it tries to push it out from the inside. That's kind of what it's doing with this. It tries to push that whole mass out in front of everything else so you can feel it superficially under the skin. But again, that's kind of a late sign, and the thing has to be huge, like baseball size, for you to be able to really feel and appreciate that, especially in some of the Cincinnati mediums that are a little heavy around the midsection. It's kind of hard to feel that. So what I say a lot of times with these aortic aneurysms, and we'll get deep into this later, and I say that a lot because I don't like covering stuff a whole lot of different times. But with these aortic aneurysms, if they have severe tearing, the word tearing would be a very common word, specifically for testing. If they have tearing abdominal pain, that's what that is. That is going to be an aortic aneurysm. And the other thing, again, thinking a little bit deeper into it, where that lives can absolutely change the blood flow to the body. So it's not uncommon for an aortic aneurysm patient to have a blood pressure that's different in one arm from the other by a lot. And again, that has to do with where that is on that aortic tree. So just some stuff to think about for that moving forward. And in hernias, there's, you're not gonna worry too much about any of that. Moving into, so we've gone from head to toe. We've made it to the pelvic area, and again, a lot of this stuff is life threats. When it's grandma that fell, it could be stability of the pelvis. The big thing that they teach you in EMT school is how to assess a pelvis. They usually say push, and if it hurts, it's bad, and that's not true whatsoever. We're going to learn a little bit more about that because, knowing that the pelvis is actually round, pushing on it from the anterior side, all that's doing is telling you that the front of it is either intact or not. So the idea for us, we're going to push on the front, maybe even one side at a time to determine specific pain. We'll push in from the sides, and we may even lift up from the back just to be able to determine where in that pelvic girdle is where the problem would be. And that's really important for us because certain pelvic injuries, specifically like significant fractures or dislocated hips and things like that, your femoral artery lives right there. And a pelvis can hold about a third of your blood volume in the pelvis going completely unnoticed. So if I could tell you like 2 to 3 liters of blood can hang out in your pelvis and me not even be able to tell from the outside and you just look like crap, as a patient, that they're just shocky looking and you have no idea why, that's a pretty big deal for us. So pelvic binders and, T-pods and some of the things that we've created in the EMS field for us to put on, they're totally underutilized because this happens more often than we ever catch. So specifically to the pelvic area, female genitalia, any kind of significant bleeding, again, that's not normal. The patient can usually tell you what normal is unless they're 10, 12, 13 years old, something like that. And this is all new to them. And in that case, a lot of times the parent might be the better option, usually mom, to try to question. But at the end of the day, hormone changes, things like that at that 10 to 14 year age, that's when a lot of these questions have to come into play, in addition to sexual activity and stuff like that, to try to determine if we're dealing with like an STD or some type of normal organic problem. So life-threatening hemorrhage, the body, the uterus in general is designed to shed surface tissue. It's designed to do that. It's designed to do this on purpose. So, until the female gets to the age where she can kind of quantify, what normal is, we're going to just kind of assume everything is somewhat normal until they're able to tell us otherwise. So as it relates to childbirth and stuff, again, that's blood loss that's going to fall into a completely different category that we'll get into at a later date. But this is absolutely an assessment that nobody's going to be comfortable doing. Just in general, male or female, nobody wants to go through the mommy and daddy parts and dig around and try to figure out if something's good or bad or broke. So just in general, just know what some of the caveats are. Know that we try to protect modesty the best we can. But at the end of the day, if there's a blood loss issue, we have to try to stop that. And otherwise, it's talking about palpating some of the like the center, the anterior parts of the pelvis. There's a whole host of different things that we'll do in trauma, but that's not necessarily something that we're gonna mess with today. Ectopic pregnancies, that is a huge life threat for us. That is absolutely a life threat. You guys, you'll hear that a lot. There'll be a lot of test questions on that in the future. None here. That's not super important, but just know that this is basically an implanted pregnancy that happened outside of the uterus. So it's in the fallopian tube. It's somewhere else. And there can be a whole host of complications up to and including bleeding and, again, life threat stuff. And then moving down through some of the other stuff, again, there's different things, pelvic infections and a lot of that stuff. And a lot of that stuff can come from the ectopic pregnancy, but it can also come from STDs and some other things. So we're just going to make notes of bleeding, discharge, swelling, lesions, stuff like that. On the male genitalia, it's a little bit easier because it's most of that's exterior and not necessarily interior. Priapism is the term that I was talking about earlier. If there's this prolonged erection that would happen typically after some type of spinal cord issue or suspected spinal cord issue, that is absolutely a clinical finding. That's something important for us to note. And in both male and female urinary incontinence and stuff like that, that's pretty important for us to get. So thinking about that, a lot of times, specifically with the female side, when you're dealing with some kind of sexual assault, there's a lot of times that we don't want to do anything. We just want to get her to the hospital. And again, we're going to try to transport with a female, practitioner or care provider. We're going to try to just keep everything kind of calm. We don't want her to change clothes. And there's going to be a whole host of things that we'll talk about in later lectures about how to preserve basically evidence at that point, just to try to get closure and try to figure out who the problem is and what's going on with her. Any questions on any of that? Good. All right, so moving down, this is kind of the last little home stretch is the musculoskeletal system. Joints, we know that's the hinging part. Skeletal, we know that the skeletal muscles, they allow us to flex and move and stuff. These are some of the common problems that we're going to have. And again, this is not stuff that we're going to mess with too much in the field as far as physically treating. We're just managing them to prevent them from making things worse. So fractures, we're going to splint. Sprains, strains, we're going to splint. Dislocations, we're going to splint. If you notice, we're going to splint everything. And the next level care provider is if they're bleeding internally, we're going to fluid resuscitate them. So we'll give them fluid. We'll do pain management. They call me the candy man because I give everybody pain meds because it's not really my job. They can be faking, whatever. There is some extra paperwork involved. There is some extra liability involved. But at the end of the day, it is what it is. If somebody's in pain, I'm going to try to mitigate that. They say pain is a vital sign. So, us trying to deal with people's pain, if I have the ability to, it would be counterproductive for me to not deal with that. So everybody gets pain meds. Again, call me the candy man. I'm okay with it. They get pain meds for me. So specifically kids, and they get it early. So that's the other big thing. So, you get a football player that's on the field, has a dislocated knee, got awful pain. And again, pediatric or whatever, generally young, probably hasn't had a whole lot of experience with pain in his or her life. But if they're laying on the football field and that you're going to have to put some kind of vacuum splint or something on, before you do all that, why would we not? So I'm the guy that literally in front of God and everyone on a football field, I'll start an IV on the 50-yard line and I'll give pain meds. Nowadays you can give fentanyl, you can give it through the nose, and I still don't think it works quite as well as IV. But I'll right there on the football field before I move him or her at all. It's something I try to prioritize because again I try to think of these patients as if it were me. And I wouldn't want to move. I wouldn't want these 3 or 4 people to move my dislocated train wreck of a leg into a traction splint that I'm not even, or a vacuum splint that I'm not really even sure how it works without being either sedated or pain meds of some kind. So we know what it's supposed to look like, and that's all this is talking about. And I'm going to skip through some of this. They talk about assessing range of motion. Again, I'm not going to do that. I am not a doctor. I am not an orthopedic surgeon. So I can ask them to raise their hand over their head. I can internally or externally rotate, or I can adduct or abduct. None of that's really going to none of that's going to fix any of this. What's going to fix this is an X-ray, some type of imaging, and maybe an MRI, all of which are at the hospital. So all I can do is kind of splint in a position of comfort and give them pain medication. And that's all I expect from you guys. Splint it in a position of comfort, make sure they have good pulses before and after you splint them, and then give them pain meds. That's pretty much our goal. That's our role in this, in the world of this. I'm not going to sit here and try to say, hey, that's the radius or the ulna that's broken, or that's the elbow joint, or that's, whatever. No, I'm going to generalize the area. I'm going to try to put together my provider's impression or my differential diagnosis. They fell. This is broke. It's pretty common. It's pretty obvious. I'm going to splint it in place again, make sure I have pulses, and I'm going to get pain meds. And that's really what it is. I'm not really in the business of isolating it to a specific area, even though this is kind of what that's showing. So palpating, their hand hurts. Again, hands and feet they take a specialist. They can't just go to the run-of-the-mill hospital. If there's some significant deformation to a hand, they probably need to go to a trauma center, even though it's just a hand. So there's just a lot of intricate little bones, and there's a lot of nerve endings. There's a lot of different things that can be broken in there that don't necessarily heal appropriately. So getting them to a trauma facility is pretty important. And likewise, the knees and the ankles and the feet, all of this stuff is really, really difficult to really pinpoint. So what they're trying to show you here is, can they extend the knee? Can they retract the knee? And I will say, probably in the next, I don't know necessarily my career, most of your career, I think what we're going to end up seeing more of is the community paramedicine stuff integrate. And a community paramedic is really just that person that's kind of advocating for not taking that patient to the hospital. It's more of that ounce of prevention is going to outweigh their actual treatment after the fact. So what they're going to see, what I think you guys are going to see is, more commonly, you guys will have the ability in the future to write basic prescriptions for an antibiotic, or some basic, very, very basic medications that prevent them from having to go to the hospital or to their doctor. And that might happen now quicker than ever, just because there's really a push now for us to not necessarily go unnecessarily to seek medical attention. So, that could be a thing as it relates to this. Some of these reductions. So, if you dislocate something, the term for you to put that back in, the term for that is reduction. So if I were to reduce an arm or a shoulder or a knee or something in the field, there could be absolutely no lasting effects whatsoever, and that patient could completely avoid the hospital altogether. So for us to be able to treat that stuff in the field would take us being able to identify it in the field, which is this. And again, this is a class all to itself, to try to figure out what range of motion and, how to physically reduce and put that ball back in the socket. So, again, that's classes all to itself. But that's kind of where they're going with this is us being able to identify the specific areas. Feet are like hands. It's really, really tough to get them to point in, point out, to move. The majority of the time that I would do any of this would be strictly to assess neurofunction. So can you point your toes to the sky? Can you point your toes, down to the back? Can you move your ankle around in a circle? Can you follow directions? That's really what it's coming down to. And do you have control over that? So a lot of it's more of a neurofunction test than anything. So the peripheral vascular system, now we're moving out of the musculoskeletal. This is kind of the last couple things that you can start checking. And again, all of this is just your assessment. So this is a lot of stuff. But again, we're hyper-focused now on what, based on our differential diagnosis from the beginning, we're hyper-focused on that particular body system that's affected. So if it's the abdominal cavity, we now know that we have to look, listen, and feel. We got to palpate all four quadrants and document appropriately. If it's the heart, we know that we have to, you have to listen to the neck and listen to the heart. You have to make sure your blood pressures are good. If we think it's a vascular system problem, we check pulses. We don't do too much with the lymph nodes. There's a lot of times, thyroid cancer is a really big one, where they can identify it because there's some abnormal swelling right here in the lymph nodes. That's a pretty important thing for them to see and understand. As a provider, for us, not so much. But again, here's that appendix in the lower right quadrant. If I push hard on that and I bend that thing over because I palpated the stomach, that's not necessarily painful, but the second blood flow restores to it. So when I let go, that's why that rebound tenderness happens, because it fills with blood again and that pain comes back, and it comes back worse because there's a surge of blood flow that was originally cut down or restricted. So, that rebound tenderness in that lower right, that's exactly what you're pushing on. But otherwise, the rest of this stuff, again, we're not going to do too much with. I'm going to skip through lower extremities, pulse, motor, and sensory. When we're dealing with that, we want to make sure that we have good pulses. Again, that's before and after, and again, that goes back to EMT school. So I don't want to go too deep into that. There are 5, so 5 of the 5 P's, they say. And again, we love in the medical field, we love acronyms. We love putting letters next to stuff. There's going to be like there's the 5 P's. There's when we get into medications, there's the 6 rights. There's a whole bunch of that stuff. And really, the only thing you can do is keep a documentation, keep a journal. If you haven't kept notes yet, and you haven't been somewhat organized, there are a whole bunch of different ways to start, and now's probably the best time, especially if you're not good at taking notes. If you're not good at taking notes, and this is a little bit off topic, but I'll mention it since it's here, the Cornell method is something that you can look into, and that's just kind of a quick Google search. But essentially, the Cornell method is you taking a piece of loose leaf paper that has the red margin line down the left side, and in the left side, you're putting down key phrases or terms or theories or thoughts or whatever it is, and then on the right side of the line, you're essentially defining it. So on the left side, you could put 5 P's. And then on the right side of that line, you can put the 5 P's. On the left side, you can put sample. And on the right, you can actually define what sample is. So that's kind of a Cornell method. That's a method that a lot of people like because it's simple. And it's easy to identify topics because they're all out in the margin for you. So things like that. If you haven't started that, I promise you it's going to help. If you do it on a tablet, if you do it wherever you're keeping your notes, if you find a way to highlight it and find a way to take some of this information and organize it in a way that works for you. So whether it's all with an assessment, so within assessment, you've got all these different things, the sample and the OPQRST and the DCAP BTLS and all the 5 Ps and all the other garbage that I've talked about today. If you put all that stuff in one spot, that might be beneficial to you if it's specifically relative to patient assessment. I don't necessarily learn that way. I learn more along the lines of, again, it's more of the body system. So DCAP BTLS would show up probably in my trauma notes. Some people like to have all the definitions in one spot. That's something for you to decide. But as of today, you're not quite too late to start that. I promise you at some point you're going to look back and go, God, I wish I wrote this stuff down. It takes a little bit more effort now. And right now we're still kind of in the early phases of learning. So now is really when you can modify that behavior and really help. I've got notes and notes and notes in 3-ring binders from medic school. And some of it, medicine doesn't change quite as often as we think it does. The medical math that we're going to get into, that's been the same since the 80s. There's nothing different. So a lot of that stuff's still relevant, and I can still go back and look at it. If you guys ever decide to do this, if you ever decide to go into instruction, having your own show notes is important. So try to keep that and try to keep it in a method that you can easily search. The unpaid spokesperson in me, I use an iPad, and in the iPad, either OneNote, OneDrive, or my personal favorite is it's an app called GoodNotes. It allows you to highlight and whatever you physically handwrite on there. If you handwrite on there, it's all searchable. So all of those things, the biggest thing is for you to be able to create something that's searchable, so that if you look up 5 Ps, you can go to the 5 Ps and you can just type it in a search bar and it'll find your notes from that. So anyway, that's kind of a soapbox on the side about taking notes, but this is exactly why, because these 5 Ps are pretty important for us to understand. So the subcategory of what you're looking at here, we know what pain is, we know what discoloration is. Paresthesia. What is paresthesia? Anybody? Nobody? So paresthesia is the numbness and tingling. That is a very, very common, very common term for us to use. It's that pins and needles. They can't really necessarily explain what it is, other than it just feels, like that, like your hand fell asleep. I'm trying to see if the book has a real good definition in it, and it probably does. Paresthesia. No, not really. That's pretty much what we just said. So yeah. So paresthesia. So they feel pins and needles. Paresis, they can't feel it at all. It's paralyzed. Or pulselessness, there is no pulse. So these five are really, really important to understand for any kind of obstruction. So again, the car wreck patient, before and after splinting. So in EMT school, they teach it to do the pulse, motor, and sensory. So motor is essentially there is the paresis. It's paralyzed. They can't do anything with it. The pulse is the same. We still have pulselessness. So PM and then S is the sensation. So what does it feel like? And we've added a couple different things to the pain. So the sensation that we're looking for is, does it still hurt? And can you feel it? So we've added a couple things to that because again, we're higher level thinkers now. So pain, pallor, paresthesia, it's some type of paralysis, and then the pulselessness. Put that in your toolbox.
Hey, Adam, isn't paresis partial paralysis?
So that's actually a really good question. Yes and no. Technically, yes, it is. It is partial paralysis, but it's referring to that specific digit or that specific hand. Taking that a step further, they get into like hemiparalysis, where literally it's just the one side. But as far as this is concerned, yes, you are correct. It is partial paralysis, and it's typically partial to that specific area. So again, you can. There's going to be different times where we're going to, like when you're associating both, if you're doing a distal, like both legs, if they have paralysis in both legs, what is that? Do they have general paresis? Do they have bilateral paralysis? A lot of it's just a terminology thing, but you are exactly correct. It is a partial or a piece of something that's paralyzed. So temperature, again, this is how do you physically do that? So, when you look at it, you inspect it, you feel it, you feel the temperature. Typically something without a pulse is going to it's going to be cool. So, obviously this is all, again, this goes back to kind of EMT school. So the spine, and I swear I keep saying we're towards the end, but we do have maybe 20 slides left. We'll take a break and then we'll come back for some of that math stuff. So the spine, knowing that we have 33 individual vertebrae, knowing what sections are that you have 12, the actual breakdown for the different vertebrae. Of this, what you're looking at here, lordosis in general is kind of an inward curve. I think there's a kind of no, that's not a good picture. Lordosis it's an inward curve of the back. The big ones you have to know are the next two. You have to know kyphosis and you have to know scoliosis. So scoliosis is the right picture. That is a normal back standing straight up, and that is just what her posture is. So that S shape, S is for scoliosis. That is kind of what that is. The center one there is somebody's back. That is kyphosis, or it's basically a hunchback. That is really, really, really important for us to understand for two reasons that I'll talk about in just a minute. So kyphosis is the hunchback, and then lordosis is that left one where the posterior pelvis sticks out way further than the back does, and it's basically that inward curvature of the spine. So kyphosis, where that's going to come into is like backboarding. How in the world do you backboard this person? You have to build all kinds of stuff with pillows. You have to try to pad the lower back. You have to try to pad the upper back, because the apex of that curve there, that is going to be extremely painful and point tender when you lay that on a hard backboard, especially with it being some type of elderly person. So just knowing what that is going to be important. The reason I say that is the last 3 times I've taken registry, kyphosis is a term that they use to describe somebody, but they don't necessarily tell you anything else about the patient. So what types of modifications do you have to make when transporting a kyphotic patient would be a question. And the questions can be like, better support airway, or better support like orthostatic, vital signs, and there's all this stuff. And one of them is pad them on a backboard. So again, you know how to treat that patient if I described it, but the fact that they use the term in the test question, that creates kind of a problem if you don't know what that is. So kyphosis, again, it's the hunchback. Scoliosis is kind of the S shaped in a back. And again, the reason you're going to need to know that is they'll tell you that the patient presents with that, and they'll ask you some kind of treatment question based on it. So when we're actually assessing the spine, we're going to look at it, which is what we did in the last slide. We're going to look and say, yep, that sucks. And then we're going to go from there, and we're going to start touching. We'll palpate down the actual spinous processes. And basically, we're just trying to elicit a pain response. Does it hurt? That's really what we're looking for. Are they up walking around? Again, I'm not in the business of being a chiropractor, so I'm not going to have them move too much. If they say there's any kind of numbness and tingling during anything they're doing, we're going to stop that, and we're going to immobilize them. Any questions on the spine? Pretty quick, down dirty. So moving into the nervous system, this is a recap from A&P. There's a sympathetic and parasympathetic spot. The involuntary nervous system is basically just that. It happens involuntarily. It's autonomic. It happens automatically. So when you're assessing somebody, again, their fight or flight is either it's either activated, or their sleep and relax, and their parasympathetic response has been activated. If you show up and somebody's in a car, and the car wreck's an easy one to go to, and they are just super chill, like they're relaxed, they're kind of slouched down in their seat, there is a possibility that there's a parasympathetic response there. And we can get into kind of why later. But the sympathetic system is that fight or flight. It's that they ripped a line of Coke, and they're out there going crazy, and that's a sympathetic response. If they get scared, that's a sympathetic response. So, and again, this we can ultimately, we'll learn later that we can trigger this with airway management. There's specific things that we can have them do to elicit a parasympathetic response. Like for example, if you bear down, like you're going to have a bowel movement, that is a parasympathetic stimulant. That is something that you can start seeing spots. It's basically your body starting to relax itself. If you blow into a straw, or you take that like an ice pack and you put it on your face quickly, all of those things will elicit that parasympathetic rest and relax kind of process in the body. Sympathetic on the other side is that you got scared, and your body is automatically going to ramp itself up. So being able to assess those differently, that's going to come into play later. The parasympathetic response, the blowing into the straw, the ice pack to the face, the bear down like the bowel movement, those are all things that we're going to do in the cardiac section, because there's certain there's certain cardiac rhythms that we can fix by forcing their body into a parasympathetic response. So that's all stuff that we'll revisit later. Reflexes, we're not going to mess with that. Doctors bang on your knee and hope something moves, hope they hit a reflex. I'm not super worried about that. I am worried about the neurological exam, which we've already covered. We've already talked about the AFPU, and we've talked about some of that stuff. As far as that coast map, I'm not a big fan of that, because basically this is just talking to the patient. If you talk to the patient and they're alert and oriented, that's good. They're A&O times 4. That's what I need to know. And if they can articulate to me that they know where they're at and what's going on, then the whole bottom half of that's been handled by just their awareness of what's going on. So I'm skipping through that. Cranial nerves, I don't want to go too deep into that, because again, we know that there's a bunch of cranial nerves out there. That picture that's in that last week's course folder in Schoology, it goes over all the different cranial nerves. What's important for you guys to understand is that they're knowing that there are a bunch of them that control different things. So for example, knowing that there is something that controls your nose and your sense of smell, and there is something that controls your eyes and lateralizing and movement of the eyes. But again, memorizing the specific ones, if you can memorize that picture, you'd be good. But I don't know that you'll ever necessarily have to present that information. Moving through, so again, balance, coordination, all of that stuff has to do with the nervous system. I don't want to go too deep into that. I certainly don't want to go too deep into this. I'm going to skip through some of this real quick. So they're going to talk about secondary, which is basically what we've already done. We've already done that. We've done a thorough assessment of the patient. The secondary assessment is basically going back through to make sure we didn't miss anything, getting another set of vitals. We're going to try to go back and check our treatments and make sure that that the treatments have the intended outcome or response. This is the secondary assessment of the trauma patient, which again, trauma patients, they need an OR. That's what they need. They need an operating room. They need a surgeon. They need us to get them there. That's what we need. And we need them to not be hypoxic, cold, or bleed out before they get there. And that's worth repeating, because that's really what we can do to save a trauma patient's life. Stop the bleeding, keep them warm, get them to the hospital in a way that they're oxygenated. So the primary injury is already done. That motorcyclist already crashed. There's nothing you can undo about that. But if they're cold, their body's going to have a really, really hard time forming clots. So that coagulopathy that we're looking for them to manage themselves, the blood flow is not going to be the same if they're cold. So we have to keep them super, super warm. These trauma patients need to be warm. We need to keep them oxygenated. Again, if they're not breathing well, then we are literally creating the problem by not giving them the oxygen that they need. So either breathing for them or assisting their opening their airway and things like that. And then getting them to that OR is really, really what they're going to ultimately need. And those are the only things that we can really affect. Rapid exam, again, we're looking for life threats. We go back and try to clean up everything else. Our documentation on this, we should put in there very specifically what our findings were originally, what they were secondarily, and then what we did and whether or not they actually fixed the problem. Pertinent negatives are important for trauma patients. So the abdomen was soft and non-tender. Just physically writing that the abdominal cavity is soft and non-tender says that it's not distended, it's not rigid, and it's not painful. So that's a pertinent negative that I write in every one of my reports. And saying that out loud, I told you guys I would post an example of my report, and I forgot. So I will still do that. Moving forward, we know about all this stuff. Keeping time to a minimum. Again, they need to get to a hospital. We talked about the EKG. We already did this in class, so I'm going to skip over that. Bipolar leads. We'll talk later about that. This is a good picture for where those leads are supposed to go. I know that's not necessarily what this class is about. However, if you want to take a snapshot of that, or if in your book, if you want to go to that's actually a really, really good picture for a lot of different reasons that we'll need later, but specifically lead placement. So you'll probably see this again, but if you've got the ability to snapshot this, that's pretty important for identifying landmarks for the dots. Give you a second for that. All right, 8 more and we're done. Promise. Monitoring devices. So CAPNO. These are critical. These are absolutely critical for a whole lot of reasons. I am a big proponent of capnography. I use it daily. This is really, really important to me for a lot of different reasons. As a clinician, so as an instructor, I'm going to be equally weighted on this. So physically measuring carbon dioxide output is what this is. So again, when I blow into that straw that's connected to my monitor, it's literally going to display how much carbon dioxide was in that exhale. And again, more internal carbon dioxide that's blown out, the higher the number. If I'm dead and not metabolizing, then that air that comes out is not going to be filled with carbon dioxide because my body is not metabolizing the oxygen. That oxygen carbon dioxide shift in the lungs is not happening because I'm dead. So if that's the case, that number is going to be very, very low because my body's not producing a byproduct. It's not using the oxygen. The oxygen that goes in just simply comes back out. So that's not going to measure. So capnography, by definition, we know that it provides a waveform that's consistent with that exhale. And again, we will use this pretty much at exhaustion for a whole bunch of different reasons. This can very specifically tell us whether somebody's alive or dead. This can literally tell us in real time the second somebody restores their own pulse. So if you get some kind of return of spontaneous circulation in the field while you're doing CPR, this will be the very first thing in real time that will tell you, hey, we got them back. That's this. This can absolutely tell you that somebody's having an asthma attack, a COPD exacerbation. The waveform that this thing spits out will absolutely and definitively tell you they are having an asthma attack right now. So if you're listening, the way it used to work, you listen, and if it's like some wheezes, yeah, they're probably having this. Maybe this albuterol will help. This will show you a picture. It will physically draw you a picture that says, "Hey, stupid, they're having an asthma attack. Fix it." So that's pretty important for us to understand. And again, whether or not they're in shock or bronchospasms, or whether or not they have some kind of acidosis, this will tell us pretty much all of that stuff. So if you can't tell, I'm pretty into this. This is going to be something that we're going to use a lot of. Glucose. The one thing I want to mention about glucose is, because of some of the cellular stuff that we talked about in the past, the glucometer does a really, really good job, obviously, of telling us what the glucose is. What it also does that we don't usually use on a regular basis, if we have a shock patient, somebody that we suspect to be in sepsis or some kind of septic shock, or otherwise, the body, when we know that the excessive use of ATP creates that byproduct of lactic acid. So the ATP is what fires the muscles. The byproduct or the waste from that is lactic acid. We know that if we use ATP too quickly, that acid will form up quickly. That's what creates those muscle spasms or the muscle cramping. That muscle cramping, or that lactic acid, when it builds up in the body, will actually register on a glucometer. It's kind of interesting how that works, and it kind of gets down in the weeds. But the simple thing is, if I take a blood sugar from a football player that has full body cramps, that blood sugar will probably be higher than a normal range of blood sugar, because again, it's essentially missing, or it's essentially registering that lactic acid system. So we in the field, we laugh about it, but we call this a poor man's lactate machine. There's $1 million machine out there that will actually do a finger stick and tell you what the lactate is, or the lactic acid is in the body. But their blood glucose can actually identify that also. So that's kind of an off-label use, but we'll talk about that also again in days to come. Biomarkers, essentially, that we're just looking at the actual printout from the 12 lead. We know that that's important. We'll get into that later. Blood gases and stuff, we're not going to mess with any of that. And then this gets into like reassessment. And again, reassessment, this right here is the slide to take home with you. Every 15 minutes, a stable patient should be reassessed. I promise you this will be a test question. Unstable patients should be reassessed every 5 minutes. So every 5 minutes, an unstable patient should be reassessed. Ms. Patrick, if I tell you that there's a 20-minute transport, how many sets of vitals on an unstable patient should you have?
4.
4. Yep, that's it. Which, by the way, might look strikingly similar to the test question that you see. So again, an unstable patient every 5 minutes should be reassessed. So if it's a 20-minute transport, you're absolutely correct. There should be at least 4 sets of documented vitals on that unstable patient. Moving on. Reassessments of the ABCs. We're going to do that. You guys are going to know all about that stuff. And then here's the thing. Here's the recap. And this really is the recap. At the end of this, did you address everything that's life-threatening? Did you prioritize what needed to be prioritized? Did you change your methods to fit your findings? So if I think that it's a cardiac event and I do a 12 lead and the 12 lead comes up negative, they're not having a heart attack, did I shift gears and go to something different? Or did I still give them aspirin and still give them nitro and still treat them as a cardiac patient? So did my priorities truly get revised? Did I do the right thing with that? And by the end of it, did you go to the right place with them? And do you have enough information to allow the doctor to pick up the care where you left off? And that's actually probably the most important part of this. Did you do enough? Did you document enough? And did you identify enough to be able to allow this patient to roll into the ER with a good understanding from the recipients, from the people taking over care? Can they just pick up where you left off, or do they have to start all the way over? Now, a lot of us feel like when we transfer care to a nurse or a doc, we feel like they start over anyway. They're going to go through their own line of questioning and their own stuff. But what you don't realize behind the scene is that 100% of this treatment's already been identified by the doc. They just have to confirm it. and you've done all the work for them. So some of the docs, some of them are very, very specific and they want to do their own thing anyway. But by and large, if you call a trauma alert, or if you call a septic alert, or you call the hospital and say, hey, I got this stroke patient, there's a good reason that they're now sending us straight to the cath lab. We're bypassing the ER. We go straight to the OB floor. We go straight to the CAT scanner. We go straight to these different places because they trust us. And they trust us because we're painting these pictures and we're doing a really, really good job as field clinicians of getting to the bottom of what the problem is and eliminating all these other differentials that are no longer active in our brains. So we start the run with 3 or 4. So we started that patient, that guy cutting grass. We started that guy with, maybe it was a pulmonary embolism. Maybe it was, maybe it was some kind of heat exhaustion, and maybe it was a cardiac event. And by the end of this, we've gone through and we've said, okay, well, let's do a 12 lead. If the 12 lead comes up positive, there's absolutely a problem with the heart, then I can remove the other 2 things off the table and I can dig right into the cardiovascular system. So I can go into vitals, I can go into repeat 12 leads, I can go into capnography. I can start doing treatment stuff. I can give them nitro and aspirin and pain medication, and I can get them to a cardiac facility. That way, at the end of it, when I'm looking at this, I can say, absolutely, I revised everything to fit what I found. All the life threats are handled. His airway is still good. His breathing is still good on his own. And he's still being circulated appropriately because of either the medications that I've given or we're doing CPR or whatever it is. And then, yes, I can paint the picture to the doc. Hey, this patient is absolutely having a cardiac event. I've already sent you a picture through the monitor. I've already transmitted a 12 lead to you. Hopefully he has it in his hand. And at the end of it, I can honestly look back and say, yes, I did everything. I documented appropriately, and I handed off care to somebody with a good story and a good representation of what I've done. And that's pretty much it. So at the end of it, we're just gonna pretty much document everything. And quite literally, that is 100% of the patient assessment stuff as a paramedic and a paramedic level. Hopefully that's not too much odd information. It's a recap. And again, the goal is for us to just dive a little bit deeper into things as we go forward, just to make you start thinking a little bit higher. So really, that's it. That's it for that chapter, and that's it for today. So we're gonna come back. I'm gonna give you some stuff to think about over the next couple of days. Between now and tonight, everybody needs to turn in this chapter's learning objectives. Between now and next day, there is no homework other than getting today's work turned in. So we finished today. When we start the next day, there'll be a quiz on Friday. There'll be a quiz on this material that we just learned. You will have already turned in your learning objectives, the specific ones that I picked out for that. And then on Friday, everybody has to come with a notebook, cordoned off, like sectioned off just for a clean slate for pharmacology. A lot of the math you'll have today, but pharmacology is where we're going to actually start next day. So you'll have a little bit of time before you have to really put your propeller hat on and figure out math stuff. And again, today, the goal of today is going to be to get you some of the basic formulas that we're going to use. If all else fails, I'm going to explain the math the way I learned it, the way I truly understand it. It's not like you don't need a calculus degree, and you certainly don't need a whole lot of stuff. A calculator would absolutely be beneficial to you. So try to have a calculator somewhere nearby, preferably not on the device that you're using. That way, if you have like an actual calculator or even your cell phone would be fine. But try to have something specific that you can do math on, and plenty of paper, because again, a lot of this stuff is just going to be repetition. If you're not a math person, we're going to start very, very, very basic. If you are a math person, just kind of bear with us. And I'll kind of scale this out to both of you. If you need additional help, we'll figure that out along the way. Again, if I explain this as we move into this, if I explain any of this stuff in a way that just doesn't sit well with you, please let me know. You guys have dealt with my wife already. She is an opposite side of the learning spectrum or teaching spectrum of me. So if you need a little bit more specific fine tuning on certain things, we'll probably start with either her or somebody else, one of the other adjunct instructors. And if that still doesn't work, somebody like Brenda is like the master's degree level instructor, where like if you really just want to get way down into the weeds, then she's going to be the person that I'll probably put you in touch with on here. Otherwise, everything that I'm going to teach you, the way I'm teaching it is the way that you're going to need it. When you go to take your national registry test, There is some medical math on there, albeit it's very, very, very limited. But they'll give you a dry erase board and a marker at your little station, so you'll have the ability to kind of do some math as long as you have a good understanding of how to lay out the formulas that we're going to go into. So again, we're going to start off real basic though today, just some basic conversion formulas. So take a couple minutes. I'm going to try to get the whiteboard on here to work, and then give me about 5-10 minutes max, and then we'll get back into it. I see this.
Yes.
Okay, cool. All right. So here's the basics. So starting next week, and let me make sure everybody's here. Bueller. All right. Real quick, before I get too deep into this, I have to take attendance at the very beginning and at the very end. If your camera is on, that is the only way that I can take attendance. So moving from here, as bad as it sounds, I absolutely you guys need to keep your cameras on so I can make sure that everybody is physically here. The other thing is the state of Ohio they're going to be doing periodic audits of us, specifically because we are one of the main, in the state of Ohio, we're one of the main classes that have primarily started online, and they're kind of interested in seeing how this is going to work. So if they pop in and there's not 16 smiling faces, that can create a problem. So I do need to see everybody's face, and I'll write down attendance as such. So Mr. Benny, Mr. Waddell. Hello. Hello.
My bad, even though I had it off.
All right. Mr. Benny, hurry up and put clothes on so you can turn your camera on for us. Awesome. Mr. Camburn, you're still on your ski lift. I'm jealous. Presidente, it's broke. All right.
Do you see the question?
Yes. So, okay. So what I recommend is separate notebook. Here's the thing with that. A lot of this is going to be scratch paper. It's just going to be, there's in your textbook, if you have a textbook, I'm going to start on page 722. And page 722 of your textbook is going to have some of the basic stuff that we're going to start on. If you don't have a textbook, it's going to be in chapter 14. There's a table. So we'll be able to go, that's kind of where we're going to ultimately fall when it comes to some of the stuff that we're doing today and some of the formulas. So that's the start of that. So to answer your question specifically, if you flip the page from there, if you are in the textbook, to page 724, you'll see a whole host of blue boxes of just garbage. There's a whole bunch of just random conversions and math stuff and intimidating looking garbage over the next probably 5 pages. That's all stuff that we're going to do. We're going to do it in small chunks though, because I don't necessarily think I don't want to intimidate anybody just yet with that. Give me just a sec. I'm looking up something else. So that's kind of the stuff. As of today, we're going to focus on page 722 though. So 722 is going to, there's two basic formulas that you guys have to understand. As far as the secondary notebook, if you're physically writing, again, just know that when you're doing some of the medical math, that's stuff that you can either keep and watch or look at later, just to kind of go back and figure out how you figure stuff out. The other alternative is that you can go through and you can just rip that out and keep just your basic formulas and stuff like that on a page. But what is important is for you to keep, and if you're taking notes today, you'll probably want to transcribe the important parts of today into some kind of formal section. So, so for example, when I give you the first formula, we're gonna kind of work through it. And we're gonna do some practice examples, and at that point, that page will kind of be cluttered with stuff. So again, if you want to keep just a list of all of your applicable formulas and stuff to be able to go through, that'll be good. So let me go back to my little screen share thing and make sure that I can do that reliably here. Technology is great, but technology is also kind of goofy sometimes. But I think this is going to be the best way to do it. So pretty pictures. Nope, we're not doing music stuff today. That's another class, I think. Fa la 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 la. I need somebody to start singing. That's what I really need. All right, it is what it is. We're gonna go with this. All right, so and excuse my handwriting, and hopefully everybody can see this. So page 722 is, and hopefully if I do this in such a way, I can just upload this to our little our Schoology folder for next week or for Friday. So the first thing I need you to understand is that there are different weights. So as it relates to weights, we're going to start with kilograms. So there's kilograms, and then slightly less than kilograms is grams, slightly less than grams is milligrams, and slightly less than milligrams is micrograms. So understanding that those are a thing. So if you start with a microgram, if it's 1 microgram, we know that it's more than that as you go to the left of that list. So 1 microgram is let me do it this way. This will be a little bit easier. So if we said 1 kilogram, and I'm going to write this stuff below it so that we can kind of see, and then I'll explain kind of how we do it. So this is 1 kilogram. This would be 1,000 grams. Okay.
Adam, do they no longer really care about the capitals versus lowercase?
So,
Because like on a copy you wrote capitals, it looks like.
yes.
And then
I'm going to write them. I'm going to write them both ways. There are times that you're going to write pretty much in all lowercase, and most of the time it's going to be in all lowercase. But to be honest with you, it's not going to necessarily matter. It's going to matter once we get into mill equivalents and some other stuff down the line. But let's not worry too much about that. But that's a good question. So the easiest thing that I want you guys to remember. So let's start with this one. Let's start with the grams. So if I want to take 1,000 grams and I want to convert it to, let's say we're going to go to milligrams. The way you do that is you have to take a decimal point, and I'm going to kind of erase this, and I'm going to use a different color so everybody can see it. To do that, technically, this is the same number, correct? It's 1,000.00. So what I'm going to do with this decimal point is I'm going to move it. If I'm going to the right, I'm going to move it 3 places to the right. So 1, 2, 3, and I'm going to put it in there. So I'm going to add my 3 zeros. So that number becomes 1 million. So all I'm doing is moving my decimal point or my period 3 places. Does that make sense? Maybe not. So let's look again. Let's do a different one. So let's do this one. So if I want to go from 1 million milligrams, and I want to go this way to grams, I'm going to take my 1 million. I'm going to take my decimal point, which is technically down here at the end, and I'm going to move it 1, 2, 3 places to get 1,000 grams. So if you start moving stuff, again, 3 decimal places at a time is going to allow us to convert these numbers up and down the chain. So if I said I wanted 1,000 milligrams, and I want that to be equal to what in grams, then that would look something along the lines of, you would take your 1,000 milligrams, and since you're moving from milligrams to grams, you're going this way, you're going up the chain, so you're moving to the left. So I'm going to move up the chain to the left, 1, 2, 3, and I'm going to put my decimal point in there. So that equals 1 gram. That is the easiest way that I found to kind of understand the conversion of this. And I'm hoping that makes sense to everybody. So again, if you're writing anything down, when you convert things, specifically kilograms to grams, milligrams, and micrograms, you're literally going to move your decimal point 3 places in whatever direction you're going on that chart. So if this doesn't make sense, and I'm assuming it's not going to make sense to everybody just yet, we will take some time to really break this down. So if I said, let's say 5 milligrams is equal to how many micrograms? So again, we're going to take our 5 milligrams, and from milligrams to micrograms, hang on just a sec. So from the milligrams to the micrograms, we know that that's going from milligrams to micrograms. We're going right on that schedule, or on that list. So I'm gonna take that, and I'm gonna go right on the schedule here, or right 3 spaces. And I'm just gonna add my zeros in. So the answer to this is 5,000 micrograms. Now, this is going to be important when we're going through medical math. So being able to convert kilograms to grams to micrograms, or I'm sorry, milligrams to micrograms, that progression is going to be relatively important for us to get. If you don't quite understand that, again, specific questions, please, right now is the amazing time to ask, because there's going to be a lot of people confused if anybody is. In a practical sense, some place that you would see this, if you need something practical to kind of wrap your head on, let's say fentanyl. Fentanyl is, you can give, so 50 micrograms of fentanyl is equal to how many milligrams? So again, we need to figure out if we're going this way or if we're going this way on the chart. So micrograms to milligrams, we're moving left. So I'm gonna go back to my number. So 50, and I'm gonna move my decimal point 5 places to the left. 1, 2, 3. And I'm gonna put, I switched colors. So I gotta fill in my 0 here. And all numbers in the world of medicine has to have a 0 in front. You can't just have this starting period, because nobody knows if that's just an accidental dot or not. So the answer to that would be 0.050 milligrams. This can also be written without this N0 here. That's this 0. You can either have it or not. It doesn't particularly matter, because again, that doesn't really add to the dose or anything. So 0.05 milligrams. So again, depending on whether we're going from micrograms up to milligrams or from milligrams back down to micrograms, that is the direction that we're going to move our decimal point by 3. Does that not make sense to anybody? And again, please ask, because this is the time to figure that out.
Hey, Adam.
Yes.
So if you're going from grams to micrograms, you would just move it 6 places, correct?
So from grams, yes, that is 100% correct. So the question was, if you're going from grams over here to micrograms, really, if you look at the number, all I did was I went from here and I moved it 1, 2, 3, 4, 5, 6, 6 places. So from 1,000, 1, 2, 3, 4, 5, 6, and that's where I got the monster number here. So yes, you are 100% correct, and it's a little bit easier when you're using smaller numbers that are more appropriate. So again, if I was saying I had, so I've got one. What do we say? So one gram is equal to how many micrograms? Again, you would take the 1 gram there, and you would move this decimal place 1, 2, 3. This would get you to milligrams, and then 1, 2, 3 would get you down all the way down to micrograms. So yeah, so the answer to that would very specifically be 1 million micrograms. So the numbers look huge. Now, I remember distinctly sitting here with the same confused face some of you guys have, going, oh my God, numbers suck. And the numbers, so 1 million micrograms. Why in the hell would I ever give 1 million micrograms? So the answer to that is that this is all theory. This is all just simply moving these decimal points around. So the fact that the dose is not reasonable is not really what I'm looking for today. What I'm looking for is you guys to be able to know that 3 decimal places, one way or another, is going to get you up and down this chart here. So if you can kind of follow that, I can take that chart and I can go to a new page, and I can basically say, let's see, where are we? I can basically put in, we can do kiloliters. We can put liters, milliliters, and microliters. So we just changed the unit of measurement from grams to liters. It's exactly the same. It's still, we're going to go from here. We'll go 1, 2, 3 to this one, 1, 2, 3 to this one, 1, 2, 3 to this one. It absolutely doesn't matter what you insert there. So again, just to do it again, just for us. So if I had, if I needed one liter is equal to how many milliliters? And you just take, we know right off the bat that we're going from liters, we're going to the right, we're going smaller. So when you go smaller, you have to move to the right. So I'm going to take my one liter here, and that becomes 1, 2, 3 spots to the right. 1 liter becomes 1,000 milliliters, which, by the way, that is your normal saline bag. So your normal saline bag, we call it a liter bag. Really, that liter bag is simply 1,000 mLs. So if you pulled out a syringe, a 1 ml syringe, and pulled out 1,000 times, you pulled out 1 ml, that would be equal. So that's important for us to understand. And then, some of us have a 500 bag. So if you had a 500 ml bag, so a 500 milliliter bag is equal to how many liters? You would take your 500, and now we're going the other direction on the chart. We're going from milliliters to liters. So I'm going to go up. I'm going up. So I'm going to move my decimal point the other way. So I'm going to go 1, 2, 3. Oh, I just had a little seizure there. 1, 2, 3. So the answer to this is 0.5 liters. So understanding the movement of that decimal point 3 times to the left if you're getting bigger, or 3 times to the right if you're getting smaller is what we're doing here. So if you can understand that is something we got to wrap our heads around first. And this can be interchangeable with a whole bunch of different stuff. Liters, yeah. So basically, the common ones that we're going to use are these. So you're going to go from kilograms to grams, micrograms, milligrams to micrograms, and then on the fluid side, and again, this is dosing for drugs. So this is typically weight, and stuff like that. And then on the other side of it, we go to the fluid side of things. So the kiloliter, the liter, the microliter. I'm sorry, the milliliter, and then the microliter at the end. That is fluid. So again, write down what you need here. So really what you need here is this stuff right here. So you're going to write down the chart that we're going to use. So kiloliter, liter, milliliter, microliter, in that order. That way you know how many times you're going to add zeros 3 times one side or the other. And then on the top, this is what we need to know here. That's the order. And again, we're going 3 times, 3 decimal places in either direction. Now, some of you pick up on this already. Some of you get a really good idea. Some of you can look at this right here, this formula right here, or just this problem, and you can figure it out. And you can figure it out just kind of by looking at it. Next week, there's practice tests, and I've got a ton of them where there's several hundred of these where you can sit and go through and do as many as it takes for you to get good at this. On the fly, you're going to need to know the milligrams to micrograms on a regular basis. That is very, very important for us. Sometimes when we get drug dosing, and this is getting further ahead, and I'm trying not to give you too much right now. This milligram, there's times where that is how the medication is packaged. So like in one vial, there's 1 milligram, but your dose should be 50 micrograms. So those don't necessarily add up without a conversion. So you have to figure out if your dose is given in micrograms, you have to figure out how many micrograms are in your vial. And if the label only gives you 1 milligram, then you have to be able to do this conversion system. And that conversion system is basically this. So if you have a vial of 5 milligrams of whatever medication, and you need to give a microgram dose, you have to convert it to figure out how many micrograms you're dealing with. So again, that was 15 minutes of just break your brain. That is step 1 of our medical math. We're going to have to get good at this, and that's this basic conversion. That is step 1. Step 2, and this is something that I want you guys to kind of start thinking about over the next couple of days. And I'll post this on our Schoology probably in next week's, so that you know where to find it. The other one that we have to know, and I am adding 2 together here, and these are 2 separate ones. Most of our medications are written in some form of weight-based drug. So if I said you need 1 milligram per kilogram of whatever medication, we have to decide, first of all, what the hell is a kilogram? Because for some reason, the metric system, they're using kilograms in medicine. They'll never tell you, you'll never see anything that says 1 milligram per pound. You'll never see that. Medicine is never set up easy for us. It's always going to be set up as milligrams per kilogram. So we have to be able to determine, we have to be able to convert kilograms to pounds. We do that by multiplying or dividing by 2.2. So you write this down. So kilograms to pounds is a dividing factor or multiplication factor of 2.2. So what does that actually mean? So we'll say 100. Let's not say 100. Let's say you've got a 200-pound person, and you need to figure out how many kilograms that particular person is. So to do that, we know that kilograms are going to be a smaller number, and you'll know that eventually. And the easiest way for us to do this is just for us to kind of memorize these formulas. So to do that, we're going to do 200, and we're going to divide by 2.2. And to do that should be a relatively simple process. So what you end up with is this big, long number of repeating garbage. And we're going to make sure that we label stuff. So this is a pound and this is your kilogram. Now in medicine, this is the answer, but in medicine, I don't necessarily care about this whole back decimal point section of stuff. So I would round up, and the answer to this question would be 91, because I'm going to round up from this 90.9. So all I did to go from pounds to kilograms, so LB to kilograms equals a division problem. So you divide by 2.2. And if you're going from kilograms to pounds, you're going to multiply by 2.2. So let's try this. So we're going to do 100 kilograms is equal to how many pounds? So we're going from kilograms to pounds. So up here, kilograms to pounds, we're going to multiply by 2.2. So down here, I'm going to multiply 100 times 2.2, and that should equal 220 pounds. So the answer is 220 pounds. What is not making sense? And again, it's normal for you to be somewhat confused right now, and I'm okay with that. Really, what I'm wanting you to do is have a little bit of exposure to these two concepts, because these two concepts are going to kind of dictate everything else. So down here, let's go back to the very beginning. So with this one, we were converting size or dosing. So kilograms, grams, micrograms. I keep saying that. I'm sorry, milligrams to micrograms. So kilograms, grams, milligrams, micrograms. And we're doing that by moving 3 decimal places. Down a page, we're doing fluid. So kiloliters to liters to milliliters to microliters. And again, we're moving 3 decimal places. So it's 3 decimal places in either direction, based on what direction we're going on that chart, whether it's to the left or to the right. And then the last one is converting kilograms to pounds and vice versa by using that 2.2 number. I will post this, but I honestly, I need a little bit of feedback right now on whether or not this is making a little bit of sense or not. Now, it's going to take a lot of practice, and I get that. You can take your own body weight later and figure out your kilograms. And again, you're doing that simply by saying your whatever pounds. Since you're going from kilograms to pounds, or I'm sorry, from pounds to kilograms, you're going to divide. So you put your body weight here, and you're going to convert your body weight to kilograms. And you're going to do that by dividing by 2.2 from your body weight. Figure that out on your own, and then figure out a couple random ones. And then figure out a couple the other way. Use your weight, use a food scale, figure something out, figure out the weight of a gallon of milk in pounds and convert that to kilograms. And you're going to do that by 2.2. What you'll find is that the kilograms are going to be smaller numbers. Mumbers is what I'm doing here. So you're going to find kilograms are smaller numbers. If you go up here, that's exactly true. Whatever your weight is down here, if you're going up to kilograms, it is a smaller number. This is 1 kilogram because that's a bigger unit of measurement. That's a bigger thing. It takes a whole lot of little things to equal that one big thing. So you're going to end up with a smaller number. So when you go back down to weight, when you're doing weight stuff, your kilograms are going to be smaller numbers. So here's your example. A 200-pound person we divided by 2.2 because we want to make it a smaller number. We figured out it's 91 kilograms. Other than some blank stares, does this sort of make sense to everybody? And again, if it doesn't, I need to know. And if it doesn't, and you don't want to mention it now, I need to know in private that this makes sense. So practice this and have this figured out, because we're going to start, ultimately, we're going to start going into some other stuff. And again, I don't want to confuse anybody, but I may say that you have so let's just say a 24-year-old male that needs a medication, and that particular medication is 2 milligrams per kilogram. Here, wait, let's show my screen, because all the writing I'm doing here is doing absolutely nothing for you fine folks. Oh God. Okay, so like I said, you may see something like a 24-year-old female that needs, let's say, it just needs a dose of whatever medication. That medication is 5 milligrams per kilogram, and let's say, and she weighs 150 pounds. And then the question will be, what is the dose? So our first step is to try to figure out how to properly apply this dose to somebody that weighs in pounds. So our first step in this program, and this is a couple steps ahead of where I wanted us to end today, but just this is kind of a practical example. So we have to figure out how many kilograms this patient is, so that we know how much of this medication to give. So we're going to do the 150 pounds. Since we're going from pounds to kilograms, we're going to divide by 2.2. And I don't have my calculator, so that is, it's like 68 point something, 0.1. So I'm going to keep it at 68 kilograms. So if she's 68 kilograms and she needs 5 milligrams for every kilogram that she is, that literally becomes a very, very simple, straightforward multiplication equation. So all we did here, and this is ultimately the end, almost the end of where we need to get. So this should be completely Greek to you guys. And if you kind of understand it, then you're way ahead of everybody else, and you're way ahead of where you should be right now. So really the age, I don't particularly care about her age. That means nothing to me. I know that she needs the 5 milligrams per kilogram, and I know that she's 150 pounds. So for every 1 kilogram, she needs 5 milligrams of this medication. So our first step was to go through and do our math equation to figure out what she weighs. We got to weight in kilograms, because again, kilograms is exactly what the question was asking, or that's what the dosing is. So we got our kilograms here. We took her kilograms, and since we want for every 1 kilogram, we want her to have 5 milligrams of the medication. Literally all we did was this simple formula down here. And then we got the final answer. So she needs 340 milligrams of this particular medication. So this is the practical application of what we're supposed to be doing, or what we're ultimately going to be doing. And again, if this doesn't make sense right now, I am totally okay with that. What I want you guys to really have make sense in your head is how to convert kilograms to pounds, how to go up and down the scale, this particular scale, and how to move the zeros around. Now, before this is ever tested on, and before you're ever going to actually have to come up with a life-saving dose on a medication based on any of this stuff, I promise you will have more practice with this than you will ever want. You'll end up pissed off at me, because we're going to do this a lot. And obviously that's a pretty big deal. If a drug medication, if I were to give somebody, if the goal of my particular whatever medication, let's say we're operating right here. This is a fentanyl dose. So 50 micrograms of fentanyl is what I'm supposed to give. If I move this decimal point the wrong direction and I give 50,000 micrograms, I now have a non-breather. simply because I moved the decimal point too many points to the wrong side of the equation. If I go the other way, that becomes a problem, and that becomes a problem in a hurry. So again, a lot of this is going to be very, very vital for us to make sure that we're not overdosing or completely underdosing our patients. So when it comes down to the medicine side, this is going to be very, very valuable for you to have kind of in your head ahead of time. So again, 3 places to the left if you're going up that chart, or 3 places to the right if you're going down that chart. And then the only other thing is the 2.2 for kilograms to pounds. And with that said, you might have some mush in there, and that's okay. I will be here all afternoon. Again, if you guys need a little more just to see this, again, you're going to have plenty of practice on it. There's some stuff in the textbook that I don't want you to get too far ahead. Don't bother doing any of that stuff. We'll do this as a class. I just want you to have a fundamental understanding of where these numbers are going to be coming from, because when we hit the ground running with the medical math, that's where everything starts to tie together in a hurry. So you'll have math, then you'll have drugs. But to be able to understand the drugs, you'll have to know what classification the drugs are. So you'll have to know what the drug is, how the drug works, and the dose, and be able to figure out the concentration, which that's all stuff that we'll get into. But the first 2 formulas for your notebook should be the kilograms to pounds, and the conversion for going up and down the units of measurement. So if you got that figured out already, you're ahead of the curve. If you don't, you're normal, and we'll revisit this again on Friday. When we're talking about pharmacology stuff. But this is the heart of your lecture stuff. This is the heart of what's making you a paramedic. You're now getting to the point where you're going to start understanding drugs. I'm going to start pulling back some of those knowledge objectives, because they're going to be important, but they're going to be practically applied. So you guys are going to be physically doing this stuff as opposed to just theorizing it. You'll have to physically make this stuff work. So instead of doing knowledge objectives, maybe we'll do some worksheets that go over these actual conversions. Moving forward, we'll add some scenario-based stuff, kind of like we did before, where you've got a patient. Here's the weight, here's the age, here's the dose. Figure out what you're ultimately going to give this particular patient, and we'll talk about a lot of that stuff. And then, because it's all starting to be an all-encompassing thing, we're going to get to a point where and we're shifting gears literally as I speak, because we're going to have to deliver the medication. So that's where we're going to start getting into different IV access points, where we're going to start looking for IV stuff. And then moving from here, it's going to be more of the practical psychomotor skill. So I want us to have this down to a science the day that we make it back into the lab to do the IV stuff, because we're not breaking this down into small stuff. Like today, we're just going to do IVs all day. There's going to be a day where we're just doing IVs, but as of the day that we make it back into the classroom, you guys are going to know not only how to start the IV in theory, you're going to be able to, I'll go through all that practical stuff, but you guys are going to know why you're starting the IV, how to draw up the medications you're going to be able to give by IV. And you guys are actually going to be ahead of where we should be right now, because again, you've got all the theory that's going to support doing what you're actually being told to do. So it's all going to make a lot more sense for you guys than some of the past classes, because you'll have the information. So hopefully your heads aren't mush. Like I said, I'll clean this up a little bit, and I'll post this in the probably the administration section. I'll probably put it in both that and the pharmacology chapter, just so you guys have access to it, just to kind of look at it as far as a template for us to go by. What kind of questions you guys have? Any? Nothing? Awesome. I will see you guys Friday. So by tonight, all of the Chapter 11 knowledge objectives have to be submitted, or all the ones that I listed in there. Those have to be done by tonight. And then we're going to start on Friday with a quiz over patient assessment. And then we'll get right into principles of pharmacology. Some of this stuff, like I said, we're gonna start writing a little bit more. By writing, I mean typing or whatever you guys decide. But medical, like medicine classes, you'll find those in the back of the textbook. And if you're not in the textbook, on the online through Navigate, at the very bottom there's a medication appendix. A lot of that, all the answers to what we're going to do, all the answers will be found back there for drug class. The difference between like a trade name, generic name, and stuff like that. We'll get into all that stuff. Just know that there's an additional appendix in the back of the book that we're going to use. What else? Anything else? Anything good in the order?
Are the learning objectives for the next chapter posted?
You're talking about for pharmacology?
Yeah, I think one of them is like an intro. I think that was the next one. Maybe it's 13.
So there's pharmacology, and then there's medical medicine administration, the med administration chapter. Those are the ones where I'm going to really try to get away from the mindless knowledge objectives. I'm able to demonstrate, as long as I can get you guys to demonstrate proficiency in some of the math and some of the handouts and some of the formulas and some of the stuff that I hand out. I think we can probably forego most of the knowledge objectives. So to answer your question, no. What you'll probably end up seeing is like an actual handout that you can fill out. And I'm trying to get it in Schoology. I'm about halfway done with one in Schoology where you guys can just go in and plug in your answers and get immediate feedback. So that's kind of what I'm going for. That way you guys can kind of go through and just start practicing this stuff. The pharmacology chapter is going to be a little bit more knowledge based than practical skill based, because it's all the different routes of medication, determining allergies, and all that kind of indication stuff for when to give a med. And then moving into the next chapter, that actual medication administration chapter, that's more of the physically how to do the math and how to draw it up and how to give it. So that's kind of the differentiation between the two. So it'll all be in there. So get chapter 11 done. If you've already done that, you've already submitted it, you're done. I'll see you Friday. Just kind of get a handle on these two theories for math. And that's about all I can ask. Anybody's feelings hurt? Good. No hurt feelings. It's always a good day.